as a consultant pulmonologist in AMRI Hospital, Woodlands Hospital, and Kothari Medical Center in Kolkata. I welcome you, sir. And we have Dr. Shamul Shorkar as well. He is a practicing senior consultant in Ranchi. His specializations are in respiratory critical care, sleep disorder breathing. He is a chairman in ICS Jharkhand and is attached to Orchid Center Ranchi. I welcome you, sir. Sir, now I request you to proceed over the conference. Thank you.
Right, I think Shiny has done my job as well. So Arjun, Dr. Khanna, I think without wasting any more time, the stage is yours. So
sure, sir. I'll just share my screen. Can you see my screen?
yes, we can.
So you can see my presentation, sir?
Yes, yes.
Sure, fair enough. So I'll begin. So good evening, everyone. I thank Dr. Parthasarathi Bhattacharya for having us here today for this very important talk on COPD. And I thank the chairpersons for introducing us. And I'll be very brief. And I think it's a very interesting topic. And I hope I do justice to it. Comprehensive evaluation of COPD. How far do we go? Now, you know, so it's a very interesting topic. And so when you talk about the evaluation of COPD, when you begin the workup of a patient of COPD, you know, when you follow the international guidelines, if you look at the GOLD guidelines, and if you try following those, especially in the COVID era, it might actually be a luxury for a lot of Indian patients. Even, what is deemed to be very basic in the management of COPD, very often we see prescriptions coming from India, wherein even the most basic things have not been done for the evaluation of these patients. So, I go back to class 8th, class 7th economics, wherein we were taught about wants, needs, and desires. Now, when it comes to the evaluation of COPD, my approach is the same. There are some wants, which mean basic, which should be absolutely done for every patient. And if you don't do them for every patient, you're not doing service to the patient. And then comes needs, needs are a little extra. And if I could do them, I would do them. But unfortunately, even in a city like Delhi, working in a tertiary care center, it is not often possible, to do everything for these patients. And then comes the desires or the luxuries, which you want for every patient, which if available should be done for every patient. But unfortunately, we hardly do it for anyone. So when it comes to the wants or the basics that I need to do to work up my patients of COPD, the very basics would be spirometry, because the diagnosis of COPD is based on spirometry. And, if you look at the GOLD guidelines, or if you look at any of the basic guidelines, they say that you need a spirometric diagnosis for COPD. You need an FEV1 to FVC value. And I'll be touching upon that again in a little bit detail, because with the advent of COVID, we are not really doing spirometry now. So how do we evaluate our patients? An X-ray chest, this is absolutely basic. You should do this for every patient. The functional capacity of a patient of COPD has to be evaluated in the first OPD visit. It is very, very important, because I'll be coming to the evaluation diagram of COPD, the GOLD ABCD chart, and you cannot, really start the pharmacotherapy of a patient unless you know what is the pharmacological, what is the functional capacity of your patient, what is the MMRC of your patient, how breathless is your patient. So you need a functional evaluation of your patient. You need a history of exacerbations, because again, your pharmacotherapy is going to be driven home by the number of exacerbations that a patient is having. Because if you look at the GOLD diagram again, I'll be going to that. The pharmacotherapy, the drugs that you need to give a patient are dependent on the number of exacerbations that a person is having. I would ask for a basic ECG and a basic blood workup, including a complete blood count, CBC, KFTs, LFTs, and a fasting sugar for all the patients of COPD. Now, when it comes to needs, which is a little bit extra, if my patient is affording, if these settings allow me to ask for them, and because, I need a comprehensive evaluation for my patient, these are some things that I would ask for in my patients. I would want a 2D echo for my patient. We all know that cardiac comorbidities are so common in these patients. So I would want a basic 2D echo for my patient. I would want to evaluate him for cardiac metabolic comorbidities, diabetes, ischemic heart disease, diastolic heart failure, hyperlipidemia. And if possible, I would want to do a CT chest in these patients. Now I'll be coming to why I want to do all these in a little bit detail. I'm just highlighting the basic points here. And when it comes to luxuries, if I could do, I would want to do for every patient. But unfortunately, if you look at Indian data for COPD, and if if we ever combine what we actually do for our patients of COPD, what I have highlighted in desires or luxuries, I think we would be doing them in less than 2% of total patients of COPD who come to our clinics, which would include a sleep study, tests for diagnosing asthma COPD overlap, because it is a big problem in our country. It is a major comorbidity, or it's a major condition in our country, and you need to really treat asthma COPD overlap differently from COPD. But we don't really do tests to pick up this condition. A 6-minute walk test, a DEXA scan, because osteoporosis is so common in patients with COPD, body composition analysis to look at the muscle mass of these patients, to look at how strong they are, alpha-1 antitrypsin levels, especially in a young patient with obstructive airways disease or COPD and lower lobe predominant COPD, evaluation for collateral ventilation and lung transplant workup. So I have listed, everything that can be done for these patients. Unfortunately, what we do is very, very basic, and I hope we could do more for these patients. So whenever I see a patient of COPD in my OPD, what are my goals? How do I want to manage these patients? I think the first thing that I need to do is make a correct diagnosis of COPD, and always, try and pay attention to the comorbidities. We've always been taught that when it comes to COPD is not a disorder which is limited only to the lungs. Lung is the epicenter. But we must teach our colleagues, our junior fellows, our postgraduates to look for tremors everywhere from this epicenter. Because COPD is one disease wherein the systemic inflammation spills over to every body organ, and unless you look for problems in those body organs, you're not going to be doing favor to your patients. You would not be able to work up your patient completely. Evaluation of the functional status of the patient is absolutely important, because unless you have the functional status of the patient, you would not be able to say the stage of the disease. And by functional status, I mean both the spirometry values and the overall breathlessness status of the patient. Because unless you have the stage of the disease with you, you would not be able to treat your patient accordingly. And of course, very, very important nowadays, any patient of COPD, you need to prevent exacerbations and slow down the lung function decline. So you need to evaluate your patients in such a way, you need to take your history and you need to redirect the workup in such a way so that you're able to, work them up in such a way that you're able to prevent exacerbations and you're able to slow down their lung function decline. So whenever I'm starting to evaluate, my patient of suspected COPD who comes to my OPD, what is the first thing that I would have had done in the pre-COVID era? I would have asked for a spirometry straight away. As per the standard GOLD guidelines, I would look at the FEV1 to FVC values. And if the FEV1 to FVC value would be less than 0.7%, I would label this as COPD in the correct clinical scenario. And then I would look at the FEV1 value, because the FEV1 value is important to look at the stage of the disease. If the FEV1 value is less than 30, this is stage 4 or very severe disease. Most of our patients, especially in the part of country where I practice, most of our patients are in grade 3 or grade 4. We very often, we get as specialists, we get patients when they are in moderate to severe lung function decline. So this is what I would have had done before the pre-COVID era, start my evaluation for diagnosis of COPD with a spirometry, because the diagnosis of COPD was to be made on the basis of the spirometry. And then after I have the FEV1 values, I would have had made this chart, which I would still do. despite not having the FEV1 values, because I think this is what drives home therapy in COPD. On the x-axis, I would want to look for how breathless my patient is. You can do that either using the MMRC, which all of us have been taught since medical school days, or the CAT score, which is a questionnaire. If you're not comfortable using these questionnaires, you can take out printouts. Otherwise, MMRC is good enough. And what you basically want to see is how breathless your patient is. If the patient is breathless on doing his daily routine activities, the patient comes to either B or D. If the patient is not too breathless, the MMRC is only 0 to 1. He's breathless on strenuous activity, he's on A or C. And then on the y-axis, you want the history of exacerbations. If the patient has had 2 or more exacerbations, or the patient has had any exacerbation which has led to hospitalization, the patient comes to C or D. We all know how to make this gold box. So prior to the COVID era, the starting point would have been the spirometry. And after that, you look at the lung function. Apart from the lung functions, you look at the functional status of the patient, and you look at the number of exacerbations, because you need to treat these patients accordingly. My fellow colleagues will be taking forward the treatment part later. But, with the advent of COVID era, how do you make a diagnosis of COPD? How do you start the evaluation of COPD? That is a big problem in itself, because spirometry, for all practical purposes, is out. It took years for spirometry to catch up. We were crying hoarse asking people to do spirometries to finally adapt this in their practice to make a diagnosis of COPD. It was considered to be the gold standard for the diagnosis of COPD, and not only for diagnosis of COPD. After 2017, gold guidelines made it a part that, it was important for us to stage and manage COPD as per the spirometric values. Unfortunately, as of now, it might not be appropriate. There are so many asymptomatic carriers of COPD, of COVID, that we see in our OPDs, and asking people to do, spirometries, we might actually be spreading the disease. So for all practical purposes, now the diagnosis of COPD is on clinical grounds and on the basis of radiology. Now, because clinical grounds, the differentials of COPD clinically can be so many, and radiologically, again, I'll be coming to the problems with radiological diagnosis of COPD, because there are so many alternatives to such diagnosis. Is there something that we can do? This is something that is very common, especially in Delhi NCR, people diagnosing COPD on the basis of a handheld device, such as a peak flow meter. Now, peak flow meter, again, the biggest problem is that the peak flow meter, even if the patient has their own individual peak flow meter, it is validated only in asthma. It is not suitable for the diagnosis of COPD, and it does not replace FEV1. So very often, our younger colleagues and the general physicians in my area, now they come up with this question that since you are not doing spirometry for our patients, can we give them this handheld device and ask them to look at their peak flow meters? The answer is no. This device is still not validated in COPD. There are modified mini spirometers. The advantage of these spirometers is that you can change the mouthpiece, but then again, you can never ever, decrease the contamination to 100%. So such small handheld devices are available. You need to standardize them every time you use them. They're robust, sturdy, repeatable. But again, the problem with such kind of devices, again, which give you some kind of an FEV1 value, would be cross-contamination. So for all practical purposes, all these small handheld devices are for the early detection of COPD. You can do diagnosis of patients in pre-symptomatic stage also in these patients, because what this device would do is it would screen out those where the FEV1 is normal. But again, the problem with any kind of a device right now is you don't want to share it between patients, because this can lead to trouble. When it comes to radiological diagnosis of COPD, Indian guidelines tell us that diagnosis of COPD should not be made on the basis of a chest radiograph. Although it is recommended that a chest radiograph should be done in the initial evaluation of COPD, because you need to look for the comorbidities, you want to look at the heart, you want to look at the bullae, you want to look at the complications, and you obviously want to look at an alternative diagnosis. Now, why should you avoid using a chest X-ray as a screening tool for COPD? Now, this is the chest X-ray of a patient who's a 40-year-old male who has an FEV1 of 84%, and he's 192 centimeters tall, a Marfanoid guy, and this X-ray, which looks normal, but because of the large lung fields, was reported as COPD. So this patient does not have COPD. And the problem is, why you should not use chest X-ray as a screening tool for COPD is because radiology does not correlate with the clinical status. It does not correlate with the FEV1 values. A patient who might have a normal FEV1 value might have a funny looking X-ray. On the other hand, a patient who has a really poor FEV1 value might be having a normal chest X-ray. However, you would ask for a chest X-ray to look for an acute deterioration in a patient with COPD, and it is not really a tool that you need every time for a routine follow-up. And every time that you see large lungs with a chest X-ray, these patients are not always COPD. Tall, young, well-nourished athletes, well-conditioned young people, singers can have larger lungs. However, if a patient does have severe COPD, it might be seen on a chest X-ray as generalized overinflation, thickened bronchial walls, vascular oligemia, flat domes of the diaphragm. You can see bullae and saber-sheath trachea. Saber-sheath trachea is nothing but an interesting sign wherein the intrathoracic part of the trachea is pulled down and it appears like a keyhole. When you talk about CT scans, we have seen more CT scans in the past 6 months than I have seen in the rest of my life, because it has kind of become a screening tool now for COVID, especially in the part of the country where I practice. But when it comes to diagnosis and screening of COPD, HRCT is not a standard tool. It can help you in identification of COPD and can pick up very early emphysema. But whether we can actually use this method or HRCTs for diagnosis of COPD is still not proven. It might give you, the advantage would be it is a very good diagnosis, sensitive diagnosis in picking up other diseases, in picking up other differential diagnoses. So the Indian guidelines of ICS and NCCP as of now, these tools have not been validated for the diagnosis of COPD in our country as a large because of financial constraints, availability issues. But with the advent of COVID, because we are not able to do spirometries, more and more of our patients are getting radiological evaluation, especially HRCT tests now for the diagnosis of COPD. Although this is not a routine practice, but yeah, this is something that has been like an adaptation to the new normal. And hopefully with COVID going down, we'll be able to go back to spirometries again. So when you look at emphysema in a patient, when you look at these few CT scans of a patient with emphysema, this is what you see. You see classical central lobular emphysema in these cuts. And this is central lobular because the attenuation starts at the center of the secondary pulmonary lobule. But then again, you would not pick up, by the time the patient has these kind of changes on a CT chest, the patient is already having advanced lung function dysfunction. When it comes to other evaluation, once you're done with the respiratory system, when it comes to the evaluation of other body systems in COPD, it is absolutely essential that we always remember that COPD is a systemic disease. The lungs are the epicenter, but the whole body is involved, and we need to do a basic overhauling in the patient. Because if you look at this diagram, the inflammation starts in the lungs, the basic pathology starts in the lungs, but the systemic inflammation spills over to every body organ possible. It leads to metabolic syndrome. It leads to the development of, higher development of diabetes mellitus. It has been associated with an increased risk of osteoporosis, increased risk of cardiovascular events. All these patients, a lot of patients with COPD have extensive muscle weakness, myopathy, poor muscle function. So it is not only the lungs which are involved in a patient of COPD, but the whole body per se is involved. And whenever you are evaluating a patient of COPD, please do not restrict your evaluation to the lungs of the patient. The whole body of the patient is involved with this disease, and you need to see the whole patient, the patient as a whole, rather than just looking at his lungs. So when you look at the relative risks or the hazard ratio of COPD with multiple cardiovascular and other, metabolic comorbidities, all the cardiac comorbidities, the most common comorbidities of COPD are associated with, COPD, and both of them add fuel to fire and go hand in hand the both ways round. For example, if you see the development of heart failure, patients who have heart failure have a higher hazard ratio of actually having COPD or developing COPD. And it's also the other way around. Patients who have COPD, the hazard ratio of these patients having heart failure is 1.3 to 1.9 times more than the general population. The same is true for ischemic heart disease, for arrhythmias, for the development of diabetes and pulmonary hypertension. So if you are evaluating your patient of COPD, you not only want to look at the lungs of the patients, but the nearest neighbor of the lungs of the patients, which is the cardiovascular system, because all kinds of problems, whether it is heart failure, ischemic heart disease, arrhythmias, diabetes, or pulmonary hypertension, all of them are seen with an increased frequency in patients with COPD. If you look at, the relative risk of development of these disorders, the most common cardiometabolic disorder which is seen in these patients is hyperlipidemia, followed by hypertension, ischemic heart disease, and heart failure. But look at the systemic features of COPD. Right from anxiety to sarcopenia to osteoporosis to cataracts to depression to lung cancer to hypothyroidism, every disease has been reported as a comorbidity in patients with COPD. So you need to phenotype your patients. Every time you see a patient of COPD, you need to take their history, you need to evaluate them, you need to take a very composite history, and then modify your investigations as per the need of the patient. If a patient has COPD and I can see the patient has a lot of sarcopenia, the patient is a frequent exacerbator. We all know that low muscle mass is an independent risk factor for the development of exacerbations of COPD. It would be paramount for me to ask for a body composition analysis of this patient. If I see a patient of COPD who looks anxious, who has a lot of depressive complaints, patient is not doing well, I would want to refer this to a psychiatrist colleague. So this is what I basically want to convey, that what is very important now is that there is no copy-paste formula for management of evaluation of COPD. Every patient of COPD is different. You need to phenotype every patient of COPD, and you need to remember that every body organ of this patient is going to be involved. So you need to redirect your investigations normally. It has been said that there's a strong correlation between impaired lung function and mortality, cardiovascular mortality. Severe COPD has been shown to increase cardiovascular disease by more than 2-fold, and it also increases the risk of hospitalization and development of hypertension. So every kind of cardiac comorbidity, cardiovascular comorbidity increases with patients of COPD, and you need to evaluate them accordingly.
2 minutes left, Mr.
Yeah, I'll finish it in 2 minutes. So if I have a patient of COPD coming to me, I would always look for their baseline blood pressure, ask for fasting sugar and lipid profiles, do at least routine CBC, renal and liver function tests. And ECG, a very easy tool, can be done in all OPD setups. A 2D echo and cardiac evaluation. Again, I was talking about wants, needs and desires. This is more of needs and desires. If you can do a cardiac evaluation and a 2D echo in our patients, somehow, even our cardiology colleagues, when they do a 2D echo, they somehow don't want to look at the right heart. Everything, is concentrated in a cardiologist's mind at the left heart. And if there is regional wall motion abnormality, everyone is very happy with it. But unfortunately, people fail to recognize diastolic heart failure, right heart failure, even in patients with advanced COPD. But you need to, force it upon your cardiology colleagues to make the lungs the heart of their practice. And if we can, we should get a cardiac evaluation and a 2D echo for majority of our patients with COPD. When it comes to ancillary tests for COPD, pulse oximetry should be done to screen for hypoxemia in stable patients, especially those who have FEV1 values less than 50%, or whenever you are suspecting hypoxia in your clinical practice, please do a pulse oximetry in these patients. An ABG or an arterial blood gas analysis is indicated only if the arterial saturation is less than 90% on room air. You don't want ABGs for all patients of COPD. Sleep study, again, I'll come to this in a little bit detail. Body composition analysis and sputum examination in India is very, very important, because if a patient has chronic breathlessness, obviously you want to rule out tuberculosis in these patients. 6-minute walk test, very important, should be done for monitoring of exercise capacity in COPD. Not only is it important for the functional status of the patient, it is very important to see the effects of the drugs. When you want to follow up your patients in the OPD, seeing whether the drugs are working in them or not, 6-minute walk test is a very important tool. If you have a younger patient who has lower lobe predominant COPD with liver involvement, always test for alpha-1 antitrypsin. And as of now, HRCT, diffusion capacity, should be done as per Indian guidelines if they're clinically indicated, if you have other differentials in mind, or whenever there is a diagnostic difficulty. When it comes to the luxuries or the desires which I want in my patients of COPD, but most of the times due to financial and other constraints, I'm not able to do them, they would include testing for sleep apnea and doing sleep studies, 6-minute walk tests, high-angle tests for asthma COPD overlap, including pheno, sputum eosinophilia, and a DEXA scan, because I know osteoporosis is so common in my patients with COPD, but unfortunately, I'm not able to do most of these tests. We do some kind of a rough 6-minute walk test in our OPDs, but I would still want to do a formal 6-minute walk test for all patients. Last couple of slides on COPD and obstructive sleep apnea, because I think this is something very, very important and we miss this out. The combination of COPD and OSA is known as the overlap syndrome. We know that smoking itself and inhaled steroids, they worsen the upper airway tone and they can worsen obstructive sleep apnea in patients of COPD. And both these diseases have a common inflammatory pathology. So if a patient has an overlap syndrome, which includes COPD and sleep apnea, this would worsen the cardiometabolic comorbidities of these patients. So I wish, I could move out the sleep study from a desire to a basic need, because most of our patients of COPD have concomitant sleep apnea. And there are so many links between the two diseases. There are common risk factors, including age and smoking, and there's a common inflammatory pathway, and both of them lead to cardiovascular dysfunction. And these patients have worse hypoxia than patients with COPD alone. They have more hospital admissions. And when you treat them, with CPAP, it leads to improvement in quality of life, lesser hospitalization, lesser mortality. So it should be actively looked for in your patients with COPD and treated. And you can see the Kaplan-Meier curve surviving there. When you have a patient of, COPD, when they have an overlap, the mortality is higher. But when you treat them with CPAP, the mortality tends to go down. So to summarize, guidelines for evaluation of COPD are not laid down in stone, especially in the COVID era and especially in a resource-limited country like ours. Because of the COVID, we are moving away from spirometry, at least for now. So our diagnosis of COPD, basic evaluation is mostly clinical and at times radiological. However, a basic workup of a patient of COPD must include looking for lung functions, the functional status of the patient, and evaluation of the exacerbation history of the patient. There are many comorbidities in your patients with COPDs, which include cardiac, metabolic, and other comorbidities. Phenotype your patient and work them up accordingly. You don't want, in an ideal world, in an utopian setting, you want everything to be done for every patient. But unfortunately, in our country, it is not possible to do everything. So how much is too much? Well, I would say at that point, I would stop my investigations where I think my patient, I'm able to help him. My patient is no longer breathless and my patient has a comfortable quality of life, and where I have decreased his exacerbations a bit. I think at that point of time, I would stop doing or investigating this patient further. Thank you very much for your patient listening.
Thank you. Thank you, Dr. Khanna. We will have the question answer session later. So we have to wait for a little bit. And over to Shamul Sharkar. I think he is already here. He has joined. He's the co-chairperson. So can I?
Yes. Thank you. Thank you.
Oh,
thank you. Yeah. Excellent talk. Can you hear me?
Yes, sir.
Yes.
Excellent talk, Dr. Arjun Khanna. Congratulations. It is a comprehensive evaluation of COPD. And as you mentioned that COPD is a systemic disease, has lots of comorbidities. So we will progress to that part now. So cardiovascular comorbidity is a very important factors in COPD patient. But it has lots of implications, particularly prognostic implications. It results in poor comorbidities, increased hospitalization, and increased mortality in this patient. But unfortunately, during our clinical practice in real world, most of the time these are underdiagnosed, overlooked, or undertreated. But we must know the details about the cardiovascular comorbidity. Regarding this, we have two topics. The first one is what a pulmonologist needs to know himself. And this will be delivered by Dr. Rahul Sharma. Dr. Rahul Sharma is a DM pulmonologist and critical care specialist. And previously he was attached with the Metro Hospitals, Noida. And now he has shifted to new hospitals. You give the name of the new hospital, Dr. Rahul. So now the chair is yours. Now you start your topic.
Thank you, Dr. Shamul,
and please give your attachment, a view attachment.
True, sir. Thank you very much for the nice words, sir. And it is pleasant to see you all on a virtual platform at least. And good evening, everyone. So I'll be talking about COPD and heart. As Dr. Arjun has mentioned that you cannot treat COPD as a lung disease individually. You need to see it as a whole soul disease or a systemic manifestation of COPD has to be treated along with the COPD management. And the most important part of this management is looking at the heart, which is just in between the two lungs. I am Dr. Rahul Sharma, and I am attached to Lee Crest Hospital that is in Ghaziabad. I am director and head of that hospital. And currently we are looking only and only COVID patients because the hospital is full of COVID patients. But my topic for today is COPD and heart, what pulmonologists need to know. I think as far as the management of COPD is concerned, Dr. Arjun has summed it up very well, that what we need to look at and how to treat this. But as far as we go beyond lungs, I think we are little shaky in management or diagnostic part of disease, but it has a very, very important aspects of management of COPD. So this will be the outline of my talk. Why coexistence of COPD and cardiovascular disease is important to us? Is there any association and increased risk of dying or even morbidity in these patients? Why it is so important to manage both heart and lung together? When to suspect, because this is the most important aspect. When the patient goes to cardiologists do their part. When the patient comes to pulmonologists do their part. But that heart-lung interaction going on in between, and probably that interaction is very, very lacking as far as cardiologists and pulmonologists are concerned. And so we need to have an integrated approach when we are seeing our patient as whole soul, as a case of COPD, and we should try to diagnose all kind of comorbidities, not only cardiovascular disease, but yes, cardiovascular disease is probably the most important part, which has a significant impact on the management part of the patient, because the pharmacotherapy that we use in these patients are a little, opposite, beta 2 agonists versus beta blockers, and all these things need to be considered when we are treating our patients. And I'll be sharing some of the evidence of pharmacotherapy in COPD and cardiovascular diseases. So this is the normal scenario what we all see when we see our old age patient, smoker, who is breathless, and we being a pulmonologist, the first thing that comes in mind is that the patient is having COPD. True. And as Dr. Arjun highlighted, that in the resource limited setting, we try to give treatment direct straight away rather than looking for the confirmation of diagnosis, comorbidities, and see whether the patient is getting some relief or not. Most of the patients do get some relief, but again, as far as the quality of life is concerned, very little people are bothered about quality of life of these patients. And that means that you need to prevent the exacerbation and give the maximum benefit of treatment, whether it is directly related to COPD or it is related to the comorbidities of COPD. Right. And we know that all the patients of COPD is at increased risk of cardiac disease because of the etiology that they share, old age, smoking, sedentary lifestyle, and so many so forth, that these patients are at risk of developing both cardiac as well as lung disease. And it has been seen, even a patient has simple lung disease, no cardiac comorbidity at presentation, they are likely to develop cardiac comorbidities, which is independently correlated with the increased risk of morbidity and mortality in these patients once these patients develop cardiac comorbidities. So it has been seen that in mild to moderate diseases, where we believe that our pharmacotherapy for COPD works well, but still these people are dying, the most common cause of death in these people is underlying cardiac condition, which can be heart failure, myocardial infarction, or atrial fibrillation. So it has been seen in literature that 1 out of every 4 deaths, which is happening in mild to moderate COPD, is probably because of underlying cardiac disease, which is a huge number. So it is very, very important that we should know what exactly do we need to treat in our patient who comes to us as a pulmonologist. We should not only focus on lung, but we need to find out that what is the exact component, or at least is there any cardiac disease that we need to treat along with the COPD management that has been discussed by Dr. Arjun wonderfully. So this is the reality versus research. In clinical practice, when we see a patient has complex cardiovascular diseases along with COPD, they are on some kind of anti-anginal drugs, beta blockers, statins. And again, considering the resource limiting settings, it depends when the patient, whether the patient comes first to pulmonologist or goes to cardiologist. So this is again very, very important, that on the basis of symptoms, the perception of the doctor changes when the patient comes to cardiologist versus a pulmonologist, because we believe in less investigation, less confirmation rather than directly going for the treatment. But cardiac disease are considered in the medical literature as and when we talk about research, then this is altogether a different subset. No research or very, very little research has directly looking into this picture of cardiac comorbidity management in patients of COPD. What they say that it has to be managed as per the individual guidelines. But most of the time, these guidelines are contradictory. As we can talk about COPD, then most of the time, this is the common perception that beta blockers should not be given. Or we talk about cardiac diseases. This is a common perception that the whatever beta agonists we are giving, these are causing more cardiovascular compromises. So it is very, very difficult to follow these guidelines in true sense of management of the patient. And it is basically for the patient or the subset of patient who has individual disease, right? This is again very, very important. This slide was shared by Dr. Arjun also, that cardiovascular risk factor is probably the most important and most common comorbidity that we see in our COPD patients, and the most common the incidence can be as high as 50% in these patients. But yes, all these comorbidities are very, very important to identify at the earliest part of the disease to give the maximum benefit of the therapy to our patient. But what happens that most of the time, all these comorbidities have a common symptoms of breathlessness, and we go by the clinical chart of COPD. Oh, breathlessness is not improving. Let's go to dual bronchodilatation. Still not improving. Let's go to ICS. Still not improving. Let's go to further management or phenotyping of our patient. But looking into the real cause of the symptoms of these patients probably gives the maximum benefit and maximum outcome. And if we are ignoring this, we probably worsening the quality of life of our patient. Patient can be dyspneic for a longer period of time, or it can replicate into the morbidity and mortality of these patients. So this is again very, very important aspects of management of these patients. So these are the facts when we talk about cardiovascular disease as well as COPD, that in cardiovascular diseases, the frequency of coexistence of these diseases together are often not recognized. We try to go by the most predominant symptoms and most predominant phenotype of our patient, whether we are treating cardiovascular disease or COPD. And symptoms are often overlapping and very, very, mixed and matched, that you are not able to decide unless you are taking a detailed, meticulous history about the patient's symptoms. The presence of COPD adversely affects the cardiovascular disease, and the same goes when you are missing COPD in cardiac diseases. In comparison to one disease alone, both the conditions have higher mortality rates, experience more exacerbation and more hospitalization, and probably have the worst quality of life. And as I have mentioned earlier, that most of the mild and moderate category of COPD patients are dying from cardiovascular disease, not by COPD and respiratory failure. So we should keep a very, very low threshold for investigation, at least initially when we are evaluating thoroughly our patients of COPD. Right. This is again the same table highlighted by Dr. Arjun, that most of these patient has an interlinked or the coexistence and the impact of one disease on other is very, very important. The most common cardiovascular disease that we see in our COPD patients are heart failure, ischemic heart diseases, and atrial fibrillation. And it goes vice versa also. If your patient has heart failure and you miss COPD, then the chances of morbidity and mortality is even higher. When we look into the incidences, the incidence of heart failure may vary from 11% to 30%. The ischemic heart disease varies from 11% to 30%, depending on whether you are doing spirometry to all your patients or when you are evaluating your patient once the patient is hospitalized with acute exacerbation. The incidence of heart failure again is the second most common non-cardiovascular comorbidities in COPD and asthma patients. The prevalence of airflow obstruction when you try to look and do the spirometry in your heart failure patients is to the tune of 40%. Atrial fibrillation or multifocal atrial tachycardia, again a very, very common scenario that we see in our day-to-day practice, and the prevalence or the incidence varies from 10 to 20% in these patients, and it is even higher in patients who have older age. When we talk about patients who are being admitted in cardiac centers, who has underlying, admitted with some kind of cardiac illness, when these patients undergo spirometric evaluation, up to 60% of these patients have some kind of airflow obstruction. And this is a very sensitive marker when we are talking about FE1 by FVC ratio. If you see airflow obstruction in these patients definitely have some kind of underlying obstructive airway disease. Vis-a-vis what we see in heart failure is a restrictive pattern of this disease. So spirometry is probably a very, very important tool, not for the acute heart failure, but the patient who are undergoing treatment for chronic heart failure, optimize on cardiac medication, not getting relief, then probably you need to look for underlying risk factor of COPD in these patients. And there is a diagnostic challenge when these patients comes to us in OPD, because most of the symptoms are common as chronic dyspnea, reduced exercise tolerance, fatigue, tiredness, increased time to recover after exercise. All these factors are so common that we often bias on the basis of physical look of the patient and rather going for the detailed history of the patient, which often gives you a good clue that if the patient has chronic cough and sputum production, recurrent exacerbation of respiratory symptoms, patient probably have predominant COPD. But if along with this patient has any kind of paroxysmal nocturnal dyspnea, pedal edema, raised JVP, hepatojugular reflex, which is now seen in books only, hardly we see any patient in the lying down position at our OPD center, heart sounds, laterally displaced apical impulse. All these features suggest an underlying heart failure in your patient. If your patient has any kind of vague or non-specific chest pain, this is not a common symptom in your COPD patient, and you must evaluate your patient for underlying ischemic heart disease. Then your patient has a history of missed beats, irregular pulse, which you need to ask, because most of the time people feel that this is common with your severity of COPD. So if you can ask these simple questions, probably that is the best way to highlight or to pick the underlying cardiovascular disease in COPD patients at a very early stage. And with this, you need to look beyond spirometry as we are talking about diagnosis of COPD. If your patient has any atypical symptoms which are not fully fitting into your COPD part, which you try to correlate and confirm with the help of spirometry, you need to go into the cardiac part of the cardiac evaluation of your patient in terms of ECG, for any rhythm abnormalities, any kind of Q waves, or any signs of ischemic heart disease. BNP, or rather anti-BNP, is probably a best marker as far as the heart failure is concerned, as Dr. Arjun has also highlighted, diastolic heart failure, which is often missed when you are looking into the echo part of your patient, and every echo comes with a normal ejection fraction. Then looking into the anti-BNP part, if it is raised, then you need to again go back to your cardiologist and request them, or reevaluate it with the help of echocardiography and look for diastolic dysfunction. But again, as highlighted, that most of the research that has been given on cardiovascular risk factor in COPD, they look into the part of low ejection fraction heart failure, and very limited data and probably a very confusing data is available on the patients who have normal ejection fraction. And sidewise, you are doing your evaluation for your COPD management. Then you also look into the probability of ischemic heart disease on your patient. There are various risk factor evaluation graphs and charts are available. You need to look for the resting ECG, any kind of previous MI symptoms, Q waves. You need to look into the echocardiography for right and left heart evaluation in terms of motion abnormalities, regional wall motion abnormalities, and try to categorize your patient into low, intermediate, and high probability. By saying low probability and intermediate probability, probably these patients are the candidates for direct startment of anti-plateletic and anti-anginal treatment. And for high probability patients, you probably go for more invasive tests to confirm the diagnosis, and the risk of this disease is so high that probably these patients need some kind of cardiac intervention for the optimization of therapy. As far as rhythm are concerned, most of the time this is the most easy part. If you can just see the pulse of your patient and you feel irregular pulse, the diagnosis is almost confirmed. But most of the time, if it comes in phases, then your Holter monitoring is required, and there is a definitive criteria for the diagnosis of AF in these patients that can be followed, and all these patients can be assessed at a very early part of the disease. But if you have evaluated your patient on these parts and you feel that your patient has no such symptoms, it doesn't mean that you ignored heart at every visit or subsequent follow-up, because even if your patient has COPD, the COPD also increases the risk of cardiac diseases in your patient as a pathophysiological mechanism by doing or creating hypoxia, hypercapnia, vessel wall abnormalities, elastase disintegration leading to oxidative stress and atherosclerosis. And you can keep on looking for such kind of symptoms maybe by clinical history or yearly evaluation with the help of ECG and echo in your patients. And you need to look into these aspects on a regular basis rather than just once you have visited and doing the cardiac evaluation. So this is very, very important that at every visit, if you feel that your patient is not behaving appropriately or not being controlled despite being the treatment as per the guidelines and optimization of the treatment, rather than increasing the dose of bronchodilators or adding some oral therapy, you should think back and see whether your patient has any underlying comorbidities which might be precipitating the symptom of your patient. This is again a very, very important part. As far as the treating part is concerned, probably both these diseases needs to be treated together because we are treating patient, not the organ. And when you treat both the diseases together, you definitely improve the outcome of your patient. And still, most of the time when we talk about treatment, there is these treatment are poles apart in terms of inhalational therapy of beta-2 agonist, muscarinic antagonist, statin therapy, and beta blockers for your cardiac optimization. So you need to be little more clear about the management part of your patient. So as far as beta blockers are concerned, which we all are afraid in our asthma and COPD patients, there is enough data now which supports that cardioselective beta blockers uses in COPD not only decreases the mortality, but also improves the survival of your patient and quality of life of your patient. So you need to use cardioselective beta blockers in your patient, which is carvedilol and bispropol. And the other long-acting muscarinic antagonist has also been shown to be cardioprotective by various mechanisms. So it is very, very important that whenever you are considering your patient for beta blockers, you should use a cardioselective beta blocker, long-acting muscarinic antagonist if required, and probably now the backbone of every COPD patient's management should be given to all patients irrespective of underlying cardiac disease. Aspirin has a proven role in the management of cardiovascular disease and decreases the hospitalization. Acute exacerbation of COPD has also been seen to be decreased in patients who are taking aspirin when these COPD patient has underlying cardiac diseases. Statins again has a proven benefit in cardiovascular optimization with the controversial data over COPD management. ACE inhibitors no doubt has to be given in your patient. So these are the beneficial effect of beta agonist on the COPD management of our patients. And the cardiovascular safety of tiotropium or antimuscarinics has also been evaluated in uplift trials, where they try to see a major acute cardiac event, and they found that the events were not significantly higher as far as cardiac arrhythmias or heart failure were concerned. This was the claim trial in which LABA-LAMA combination has been seen in evaluated in the cardiac function in COPD patient, and they found that there was a significant improvement in the cardiac function as measured in left ventricular end diastolic volume, and overall improvement was seen in patient who has underlying cardiovascular diseases. So this is very, very important that the pharmacological aspect has to be dealt in detail, because once you have diagnosed your patient as some kind of underlying cardiac disease. It is not always possible that every time patient has to visit 2 doctors for the management of their disease, right? So basic things can be done at pulmonologist, and also when we are suspecting any kind of underlying cardiac disease in our patients. So an integrated approach is probably the best way, in which you evaluate not for the COPD, but also for the underlying comorbidities, and cardiovascular disease is one such comorbidities that has to be evaluated, because the symptoms are so much overlapping that if you ignore these symptoms, patient might land up into a significant cardiovascular disease, which probably may not be reversible, or you cannot give that much of benefit in the later part of the disease. Again, for COPD diagnosis, spirometry is the gold standard, and for cardiovascular disease, you need to have an overall assessment tools in terms of clinical symptoms, echocardiogram, ECG, and when need, you need to. I have just 2 more slides. Yeah, I have just 2 more slides, sir.
Okay.
And so this is very, very important. Whenever you feel or you are in doubt, I think that is probably the best time when you interact with your cardiac colleagues. So this is the last slide, that we all see multimorbidities in our COPD patient, and it is always a challenge to find out the correct underlying disease, which is not the main symptom of your patient, or most of the time these symptoms are predominantly driven by the COPD part of the disease. But it is very, very important that you should able to identify at least these 3 diseases in your patient, which has highest morbidity and mortality in your COPD patient, which is heart failure, ischemic heart disease, and atrial fibrillation. And integrated approach from the beginning, not only sticking to the gold guidelines, but look into the comorbidity part of gold guidelines is probably the best way to provide the maximum benefit of management to your patients. And cardiopulmonary interaction should be happen in, I think, all the patients. When you are evaluating and when you are in doubt, please interact with your cardiologist and eat their head that you need to rule out any underlying lung disease. So this is probably the best time of interaction, as the body is the lung and heart is interacting inside the body. We must interact with our cardiologist outside. Thank you very much for your patient listening.
Right. Okay. So thank you very much. Sorry, Dr. Sarkar.
Yes, yes. Thank you, Dr. Rao. It is a very, very gist and comprehensive lecture on the correlations of comorbidity of cardiovascular problems in COPD, and what a pulmonologist should know. Now, the next topic is related to, again, the same comorbidity with cardiovascular with COPD, but this lecture will be on what the pulmonologist needs to know from a cardiologist. And the speaker is Dr. Sumit Sengupta.
Good evening, sir. Can you hear me?
Yes, yes.
Yeah. Can you hear me?
Thank you very much.
Yes.
Yes,
yeah.
Everybody can hear.
Go ahead.
Can you see my screen?
No.
Hang on. Now? Is that better?
Yes. Make it full screen.
There you are. Right. My work has almost been done by my preceding 2 speakers, and so I will be taking a little bit of a meander and a few slides, which I'm sure you're all familiar with, and most of it has already been said. So what does a pulmonologist need from a cardiologist? Now, let me start off by saying I don't consider myself a pulmonologist. I'm a respiratory medicine specialist, which includes things apart from the lung, part of them in the heart as well. For example, pulmonary hypertension, I believe, is a pulmonary disorder, not a cardiac disorder. And we talked about phenotypes of COPD, and it's quite important to understand that COPD is not a single disease. And the most classical example we talk about is airflow limitation due to smoking, but there are other varieties. But from the beginning, it's apparent that we need to individualize our treatment and look at things how they are. Now, I will start with a story. My colleague, who is now head of department of gastroenterology in a multinational hospital did a thesis in 1992 on the diastolic dysfunction in COPD, right ventricular diastolic dysfunction. And he found, to his surprise, that one patient who had been diagnosed as having COPD had actually very tight mitral stenosis. And this patient had bounced around a teaching hospital, cardiology, and respiratory department for years before an echocardiogram sorted out his problem. And obviously, he went on to get proper treatment. As has already been said, FEV1 is an extremely important cardiovascular risk factor. And I would like to focus on measuring of it, because one of the most important problems we face is we see people who have both ischemic heart disease and COPD, but unfortunately have never got around to getting a 1,000 rupee test of spirometry, and sometimes are on inhalers empirically, and sometimes nobody's picked up that the patient is COPD. As has been mentioned before, a lot of patients with COPD die of heart disease, and in certain segments, they actually overshadow respiratory disease, and sometimes that happens in patients as well. So one needs the cardiologist to get a spirometry. And just to disagree slightly with one of my previous speakers, I think even in the era of COVID, a diagnostic spirometry can be done. There are ERS guidelines. We are following it in our hospitals. It takes time. It's more laborious, but it needs to be done, particularly not just for follow-up, but for diagnostic processes, it should be done. Now, apart from getting a spirometry, what would you like your cardiology colleagues to do? You would want them to diagnose heart failure. Now, it's easier said than done. And there are multitude of papers and review articles written on how to diagnose heart failure. In the age group of smoking COPD, most of the heart failures are not systolic dysfunctions, but they are heart failure with either normal ejection fraction or mid-range ejection fraction, which is what we need to we need to tease out very sort of finely and almost under a microscope and try and treat it. For mid-range ejection fraction heart failure response to systolic heart failure treatment, and reduced ejection fraction, well, that's a very difficult chapter which we might discuss if you have the time. Most of this heart failure is undiagnosed, and the blame falls equally on primary care physicians and respiratory medicine specialists as well as cardiologists. And again, to disagree with one of my previous speakers, a 2D echo, if you get a COPD patient to echocardiogram, you should never ever get a 2D echo. In today's day and age, when you touch an echo probe, it has to have a Doppler, and you need to get all sorts of LA filling pressures, you get the RV function, and you have E by E prime, and all sorts of things, LA filling, LA size, and all sorts of things. And one can, in most cases, but not in all, diagnose heart failure with or without COPD in patients who present to a combined care of an acute medical unit. It's not just restricted to acute medical care. In the outpatient also, one tends to not really look at these patients, and you just look at the spirometry, or maybe just listen to their chest and look at their sats and just prescribe an increase in inhaler or not. And sadly, it is well known that heart failure increases the mortality of COPD patients, whether in the outpatient or as inpatients. But treatment of heart failure did not improve with over a decade in this one of the largest longitudinal databases from the United Kingdom. And the other issue is ischemic heart disease, which is one of the other common sort of, let's say, triumvirate of cardiovascular disease we see in COPD. Beta blockers post-MI, as is seen in this study, and beta blockers for heart failure are 100% indicated in COPD patients, even the most severe patients. However, I would draw a line at hypertension, and if people are getting beta blockers for hypertension, I would tend to try and decrease it or replace it with more effective drugs. The reason for that is this study, which showed that if you don't have an accepted strong indication for beta blockers, metoprolol, which is a cardioselective beta blocker, increases hospitalization for exacerbation, and you need to focus on the individual causes of beta blockers and not say that beta blockers per se are good for COPD. They aren't. They are good for cardiovascular diseases which require beta blockers, and not giving them increases mortality. But if you don't have a really solid indication, you may actually worsen the situation. So again, individualization. The third of the triumvirate of cardiac disease, which we see quite often, and you see it not only in COPD patients, all of these patients, are atrial fibrillation. Sometimes it's just missed. We don't do ECGs that often, but often it can be picked up just by feeling the pulse. So it's not something that should be missed. And the treatment of atrial fibrillation has advanced substantially, starting from easier to apply anticoagulation than NOACs, and also non-pharmacological treatments of atrial fibrillation. And also there is evidence that appropriate treatment of atrial fibrillation, be it paroxysmal or persistent, decreases mortality and acute exacerbation of COPD, which it's related to. One of the other things, as I sort of touched on at the beginning, is that you misclassify heart disease as COPD or vice versa. We have had occasion to exhaustively look at people who have been diagnosed as having COPD, as on inhalers, triple therapy, whatnot. And we discovered, to our surprise, that there's a little bit of diuretics and some ARBs. After evaluation for heart failure and treatment of heart failure, the COPD vanishes. One must remember that spirometry, though it's the sine qua non of COPD diagnosis, is also obstructive in heart failure, both chronic and acute heart failure. And one needs good old-fashioned trial of diuretics and heart failure management, particularly if it's a crackles predominant COPD. And one often, though, finds that that is quite rewarding. The flip side is, if you've got a patient on inhalers where you're not sure whether the patient has COPD, but the patient has heart failure, there is an increased risk of all-cause hospitalizations. So if the patient has COPD, beta blockers, beta stimulants are okay. There is some suggestion, however, that short-acting beta stimulants like salbutamol and ipratropium actually might be harmful, and longer-acting ones are safer. So not absolutely so. In the context of COPD and heart failure, they should both be given. Both beta blockers and beta stimulants, particularly long-acting, may be used. Now, it goes without saying that the heart and the lungs are in circuit, and they work together. So you need to have a combined, as my predecessors pointed out, combined effort at sorting out these problems. So what can you do to quantify how much heart and how much lung? That's a very common cause for referrals in our acute medicine unit. How much heart and how much lung is the cause of the respiratory problem? And one needs to quantify. We've talked about Doppler echo, not a 2D echo. If somebody has mentioned the brain natriuretic peptides, which are useful, but they are too broad spectrum, and they are useful when they're very high or very low. In addition to that, there are a lot of invasive tests which are done not so often, but should be applied to people who are probably in hospital, including cardiac MRIs, which can pick up various causes of heart failure, including heart failure with preserved ejection fraction, as well as coronary angiogram to look at LV-EDP, if that's what you want to do. If you do an angiogram, it takes 30-40 seconds extra to just measure the LV-EDP, and Bob's your uncle. At the same time, you can also assess for ischemic heart disease with fractional flow estimation, and assess whether anti-ischemic therapy, be it pharmacological or stents, are going to be helpful. We need the cardiologists to be interested in the patients and individualize rather than saying, oh, this is heart failure and this is COPD and heart failure. And really maintaining that interest is part and parcel of what we should be looking from our colleagues as well as from ourselves, actually. So the call is for integrated care, but also the call is for care of the individual patients with a particular set of situations where certain heart failure with normal ejection fraction may respond to just a very small dose of diuretics, but will actually get worse when and if if you give too much diuretics. Sometimes a beta blocker is helpful, sometimes an ARB is helpful, and essentially what we need in this situation is getting together at the bedside, not just somebody referring patients to a cardiologist or vice versa, and looking at the patient's therapeutics and extending investigations as far as possible into the pathophysiology of that particular patient's current problems. Once you've delineated these problems, it becomes very easy to treat the patients. However, remember that the same patient one day could come in with a heart failure and the next day can come in with a raging COPD exacerbation with no evidence of heart failure. So just saying that this patient has heart failure and COPD is a time-bound phenomenon. You cannot really just stop and give him the same treatment. 2 days down the line, that diuretic might be causing him renal failure, and he had to pull back on that and increase his bronchodilators. Atrial fibrillation is easy to pick up if you are assiduous in measuring your pulse, or even look at the pulse oximetry. That will tell you a lot. And certainly, one needs no real expertise to call in a friendly neighborhood cardiologist and ruminate beside the bedside of a patient, provided you have the time. Thank you very much.
So thank you, Shumit. We are going to have a question answer later once we finish the whole program. And the next speaker, may I call on Dr. Sarnaik, Dr. R. Sarnaik, and he will be talking on bronchodilator in COPD selection and prescription. So over to you, Dr. Sarnaik.
And so please allow the conductors who are conducting the meeting to give us the introductory slide here, please.
Dr. Sarnaik seems not have joined yet. There is some problem on his side.
I think, am I heard?
Yeah, Dr. Sarnaik.
Yes, yes.
Yes.
There.
Hope the slides are visible now.
Yes, it is. They are.
Yeah. Am I audible? I think.
Yes.
Sorry for the initial teething connectivity. Thank you very much. First of all, let me thank Dr. Partha for having thought of me to discuss this topic of bronchodilators with the pharmacology therapy for COPD. As all of us know that bronchodilators per se are the symptomatic treatment to cause bronchodilation, improve the airflow. And of course, in COPD, one also knows that there is a selective or a localized or a diffuse hyperinflation or air trapping as well. So it's a combination of pathophysiology one has to tackle, and we have to selectively use proper bronchodilators in a selective dosage, in the proper dosage, therapeutic dosage window that is available to us. And one should also understand that there are limiting factors for use of bronchodilators, especially when it comes to the higher permitted window or therapeutic window for these patients. As we know, the types of the drugs that normally are available with us now although there would be lots of under research or currently under research phase 2, phase 3, I will not go into that. The practical tips, the beta-2 agonists, which again subdivided into long-acting and the short-acting ones, and the anticholinergic drugs, which again have long-acting and the short-acting wings. And of course, over last current 2 to 3 years, now we understand that monotherapy for COPD, especially when it comes to moderate to severe COPD, possibly is not the right way of approaching these patients, primarily because we have to look into the future lung functions, the preservation of lung functions, and of course, the current therapeutic benefits to the patient that one has to decide. So when we look at the available drugs to us, our primary goal would be to prevent and control the symptoms, reduce the frequency and the severity of exacerbation. Because over last 2 years, the updated gold guidelines has given a lot of due importance to the exacerbations, and whatever currently available new drugs that actually are coming in, they are primarily getting evaluated. How is the potency or the potential of that drug to reduce the exacerbation, because that is known to adversely affect the lung functions of the COPD patients in future, improve the overall health status of this patient, and of course, the exercise tolerance will be more area of focus for moderate to severe patients. So just to have a brief overview that although we are going to focus today's discussion and the bronchodilators, it is the combination of bronchodilators, and in addition to that, it also requires a lot of other supportive therapy. If the patient has hypoxia, he may require supplemental oxygen. And of course, if there is too much of airway inflammation or patients who fail to respond to the combination of highest permitted beta-2 agonist dose, we might have to add on inhaled corticosteroids. Again, as we can step up these doses and add on these drugs, we will not actually look into the supportive drugs therapy for here. The long-acting bronchodilators, we will quickly go through the moderate airflow limitation as scheduled with long-acting bronchodilators. The overall symptomatic benefit, especially the nocturnal benefits of maintaining good bronchodilation, is definitely caused better by long-acting bronchodilators. Regarding to the compliance of the patient, the short-acting beta-2 agonist, invariably patient would need to take frequently, too many times in a day. And of course, they will also have intermittent symptoms and exacerbation. So that is one of the preferred drugs now. It has also been shown that it definitely helps in the number of exacerbations and hospitalizations of these patients. So it must be given in short-acting bronchodilators for acute relief. Whenever patient has exacerbation, quick relief, beta-2 short-acting drugs. However, in long run, long-acting beta-2 agonist drugs. The short-acting bronchodilators, as and when required, can always act as an excellent support for this patient's symptomatic benefit, and the short-acting will be salbutamol or ipatoprene bromide. The long-acting will be, patients will require to take them on at least a 12-hourly basis, but sometimes they may require it on every 8 hours, depending on the selection of the drug. The combination is definitely have been shown to have better improvement in the lung function of these FEV1 values of this patient. So in that term, combination dual therapy is one that is over last 1 decade practice for COPD patients. The bronchodilator side effect also needs to be considered before we tailor make the patient's treatment. Most of it, whenever the excess doses are used, or some patients who are hypersensitive to beta-2 agonists may have tachycardia, palpitations, muscle tremulousness. Of course, in the higher doses, sometimes hypokalemia, prolonged QT interval. These are the most of the side effects that are known to all of us, but in COPD, invariably they will be elderly population with coexisting comorbidities in the form of ischemic heart disease, systemic hypertension. So one should be a little more cautious while prescribing these drugs on a higher doses. Similarly, anticholinergic drugs in the elderly patient would have dryness of mouth, constipation, sometimes they have difficulty in urination. So one has to keep this in mind before we prescribe. Although they are inhaled drugs, they will have in higher doses systemic few of these side effects in selected patients. So long-acting beta-2 agonists in along with the long-acting muscarinic drug, we will have a better tolerance if there is no evidence of using these drugs, the long-acting LABA and LAMA together. There is no increased frequency of systemic toxicity or local toxicity in the oropharyngeal. So long-acting anticholinergics have also been well evaluated. I will not enumerate all the studies, but what has been seen is there is insufficient evidence of using these drugs in long run, especially as a bronchodilator in dual combination, that is LABA-LAMA therapeutic window. The long-acting anticholinergics and the short-acting, again, beta-2 agonist as well as anticholinergics may be required as a supplementation as and when the patient has exacerbation during the treatment. Due to scarcity of time, we are going to rush upon few of these known things, that is the pharmacology and the side effects. And the next drug that one should consider is supplementing these patients with theophylline. We are trying to just have the look at these drugs because they are available, they are being used. However, we know that as to understand the potency of bronchodilation with beta-2 agonist is maximum in bronchial asthma patient as against in COPD. The LABA and LAMA combination works better, and antimuscarinics will definitely be the choice of drug for the patients of COPD, predominantly COPD. However, some of these patients will require drugs like theophylline. As per the GOLD guidelines, we can take help of these drugs to support to our patient's lung function, especially for chronicity of these symptoms and the control of the airflow limitation, or few of the patients will require it depending on the lung function test and the symptoms. I will come to that in the later half on the discussion. So of course, we cannot overlook the supplement of inhaled corticosteroids, which actually, because it acts as an anti-inflammatory in few of the patients, especially more so for the patients who have bronchospastic like overlap syndrome, or patients who are having eosinophilic count going high. They are the one who definitely respond to inhaled corticosteroid, which may not be actually bronchodilators, but they will have to have some benefit, synergistic effect with bronchodilators in managing these patients. So invariably now the pharmacological therapy as per the GOLD guidelines has been a combination of LABA-LAMA and supported with inhaled corticosteroid. These I have just touched upon two of the inhaled corticosteroid slides, because these are the few of the combinations also available in market might benefit to the selected patient. From here on, we will know that they are the short-acting beta-2 agonists. We need not enumerate the list of that, but the salbutamol, levosalbutamol is all of us are using very frequently. Long-acting salmeterol, formoterol, and formoterol are the drugs most of us have been using. And of course, the anticholinergic mechanism of action, it blocks the acetylcholine on muscarinic type 3 receptors. So they are pretty selective in receptor selection, and it doesn't cause much systemic toxicity, and it does result in good bronchodilation in COPD patients. These are the drugs: ipratropium, long-acting tiotropium, and the combination. And of course, glycopyrrolate and other drugs are available in market now. These are the combination drugs which are available either in beta-2 agonist, short-acting, or long-acting anticholinergic. Again, the corticosteroids in some of them as a combination, because it is available. I have just tried to put it into the slides here. And of course, inhaled drugs are preferred as a dual therapy. Now, most of the studies have shown this. So how do we look at the anti-inflammatory set of drugs? On your right-hand side and on the left-hand side are SABA, LAMA, and LABA, long-acting. And of course, a combination, as I have said, like there are now newer long-acting, safe LABA-LABA combinations available, glycopyrrolium. As you can see, indacaterol, these are the drugs which apparently are little expensive to start with, but they have been shown to have the long-term advantages because they are once a day. They have less side effects, and the exacerbations and the number of hospitalizations in these patients have been shown to be much reduced. In addition to that, they don't have much, the safety profile has been quite good when it is used for long-term management for this patient. Quickly going through the guidelines of the GOLD, as one can see now, we have to subdivide these patients into A, B, C, D. And of course, we have to look into their CAT score, that is the symptomatic symptom score, as well as we have to take supplement of doing support by doing a lung function test of these patients. If there is a significant reversibility, of course, we have to subclassify these patients separately. But anybody who classifies as per the spirometry in COPD, we have to categorize them in these 4 groups. And then, of course, we have to see that the LABA-LABA combination, to start with, every patient will require simple bronchodilator to start with. And then, of course, we have to step up the therapy as shown in this graph. From group B, you can add LABA and LAMA combination. And of course, if the patient has more exacerbation, more severe symptoms, we can scale them up to by adding inhaled corticosteroids or theophylline supplementation. Of course, group C patients, some of them LABA with ICS may be their maintenance therapy for a long-term patients. So just to summarize these groups, I think just to make it easy, the guidelines, the GOLD guidelines have been revised over last 2 years again. There has been few subtle changes, new things added on. So guideline recommendation, one should resort to the updated GOLD guidelines every time we are looking at the subsets of the patients of group A. And then of course, group B, most of the times recommendation as well as the clinical benefit has been shown to be combination of LABA, LAMA in this group of patients. Of course, group C may require inhaled corticosteroids in addition, but as we do in bronchial asthma also, we need to review because these are the initiation of treatment for the patient symptom benefit. Beyond initiation of treatment, one has to monitor these patients over a period of time in terms of their symptom score, in terms of their lung function, and then review these patients again. And to consider a long-term therapy for these patients, we have to either scale down the number of drugs or we have to increase the number of drugs depending on the symptom score of these patients and clinical objective evaluation for these patients. So spirometry would be one of the important essential elementary evaluation to confirm the diagnosis of COPD. Thereafter, we'll have to assess into the airflow limitation, the obstruction. FEV1 value would definitely determine for these patients. Of course, then GOLD 1, 2, 3, depending on the FEV1 as shown, less than 80%, less than 30% will be GOLD 4. And of course, we have to look into the CAT score for these patients or the MRC score, and then subclassify these patients. And I will not go into details of this, but we need to have some algorithm. The new thing that has been added is after initiation of the treatment, last GOLD 2020, important thing is to review these patients based on ABCD assessment schemes, and then symptom scores, if it is substantially reduced or if the patient is feeling better, we have to follow up these patients with the algorithm. And of course, we have to step down this treatment. Mostly inhaled corticosteroids can be stepped down in the follow-up of these patients.
Please wind up. Please wind up within 2 minutes, yes. Please.
I think I have already just a slide or two. I think we can just have a look at this slide, because this is going to be a repetition of LABA, LAMA. We will have more question answer sessions. I think I can end here. Thank you very much.
Thank you very much.
Yeah.
Thanks very much.
Thank you, Dr. Sarnaik. So our last presentation will be by Dr. Agam Bora, and the topic is the dilemma of using inhaled corticosteroid in COPD. As all of us know that inhaled corticosteroid is not the drug of choice for COPD, as it is the drug of choice for asthma, but in practical, in the real world, more than 50% of the COPD patients are getting ICS in either combinations with LABA or this triple combination. So we will learn in detail about the inhaled corticosteroid, use of inhaled corticosteroid in COPD, a critical appraisal by Dr. Agam Bora. And before starting the lecture, I will request to please give the slide on introduction of Dr. Agam Bora.
Before we start with Dr. Agam Bora, I would request one of my fellow mates who is also the announcer in this session to kindly proceed over just for 1 to 2 minutes to have a brief introduction of our presentation. Just one slide, we would like to announce something in this session. Post that, we can start with Dr. Agam Bora's session.
Yes,
kindly
fine.
Allow.
Fine.
Shayoni, over to you.
Is this audible? Am I audible?
Oh, I thought it was Diwali going on there.
Yes, yes, Shani, you're audible. Kindly proceed over the session for a minute.
A very good evening. This is a innovation that we have built for our institute, and it is our request for all the participants to kindly register for the seminar on Wednesday 18th, that is 2020. The topic is about the two-chair test, a special talk for Pulmocon, and it will be preceded by Dr. Parthasarathi Bhattacharya. This 2-city innovation is a substitute for 6-minute walk test that we have developed in our institute. So I request all the participants to kindly register. Thank you.
Thank you very much,
Now I
Shani.
request Kaushik to kindly share Dr. Vora's talk.
News conference, Pulmocon. And today I'm going to be talking about the critical appraisal about the role of inhaled corticosteroid when it comes to COPD management. At the outset, I must express my sincere thanks to my teacher, Professor Director Dr. K.C. Mohanty. Of course, all of you who have decided to log in for today's program and are there to encourage me, all my patients who gave me unconditional love and gave me opportunity to learn my respiratory medicine. COPD is one disease, we all know that, where the global burden is rising. It is marching to become the third most common cause of mortality. We have a huge number of COPD globally and in our country. Over years, our understanding for COPD has changed. The way we were looking at COPD in 2015 is it is a chronic obstructive pulmonary disease, a common preventable and treatable disease characterized by persistent airflow limitation, which is usually progressive, associated with enhanced chronic inflammatory response. It also spoke about exacerbation and comorbidity contributes to overall severity in individual patients. And now we believe, or we understand, or we have revised definition as it is a common preventable and treatable disease that is characterized by persistent respiratory symptoms and airflow limitation, which is due to airway and or alveolar abnormalities usually caused by significant exposure to noxious particle and gases. And if you see that, we have removed certain words like progressive, enhanced inflammatory response, exacerbation, comorbidities, etc. And why is so? There is a reason for including persistent respiratory symptom because all of you here would believe or agree with me, it can occur even before development of airflow limitations. Clinically, you feel you are dealing with a case of COPD and there may not be airflow limitation at that time. It may exist in patients with normal spirometry. There may be other evidences of lung disease like you may have a history of smoking and a classical clinical presentation. You may have a radiology which talks about emphysema, airway thickening, or there may be gas trapping. And today, you cannot diagnose COPD based on symptoms alone. So when you have a particular presence of shortness of breath, chronic cough, and sputum production, and a patient giving history of occupational hazard, smoking, or host factors which are relevant, you have to do spirometry. Spirometry is must for diagnosis of COPD. And you have FEV1 by FVC. When it is less than 0.7%, you know it is obstructive lung disease. You give them bronchodilators and look at the reversibility. If there is inadequate reversibility, you confirm the diagnosis of COPD. We were looking at COPD earlier based on this matrix. We were looking at CAT scoring or the MRC scoring. We were looking at risk of exacerbations and we were looking at severity of airflow limitations. And we would take these three variables into consideration and we had 4 particular quadrants, A, B, C, and D. But over time, we realized in 2016, we probably got the revised COPD, combined COPD assessment tool. And we realized that airflow limitation probably created confusion. This particular tool did no better than simply the spirometric grading. And group D, if you see, it can be modified by 2 factors. So either a severity of airflow obstruction or number of exacerbation could probably put you in that zone D, and that would lead to confusion. And hence, probably a revision was required. In 2017, this particular spirometry was removed out of this matrix, and hence the assessment became very simple. So you have a simple 3-step assessment. You would confirm the diagnosis. So you have a classical presentation, a history of exposure, smoking, and some environmental factors, and you have cough and sputum production. You would do their spirometry. You would confirm the obstruction. Depending on, once you confirm the FEV1 by FVC of less than 0.7, you're talking about obstructive airway disease. Post bronchodilatory, there is no improvement. That means it is a case of COPD. Once you confirm that, you look at FEV1 value. The FEV1 value would tell you about, less than 30% would put it as severe and more than 80% would put it as mild. So mild, moderate, severe, and severe. You will have that 4, grades, gold 1, 2, 3, 4, depending on FEV1 values. But then you don't consider that into looking at this matrix. So when you put patients in matrix, you would consider only two variables. One is MRC or CAT scoring, and second is risk of exacerbation. So patient having 0 or 1 exacerbation would be probably either A or B. Patient having more than 2 exacerbation or single hospitalization, put them on C and D. And based on their MRC scoring, if they are less symptomatic, CAT score of less than 10, probably A and C, and CAT scoring more would be B and D. This is classical FEV1 values. Based on that, you would look at the severity of obstruction, but you will not take that into consideration while designing that matrix of choosing the therapeutic options for that particular patient. These are ready-made charts available where you can judge the severity based on CAT scoring. Classically, less than 10 would be low, and anything between 10 and 30 would be moderate to high severity. That means patient is suffering more. And then we have a classical MRC grading, 0, 1, 2, 3, and 4. 4 will be patient is by and large breathless on doing simple activity. He is bedbound or is moribund. That would put him in the severely symptomatic patient. So your previous approach, you diagnose a patient, put them into group A, B, C, and D based on airflow limitation, symptoms, and number of exacerbations. Now, what Gold tells us is you diagnose the patient, do spirometry, judge the severity, but take only two variables, that is symptoms and the number of exacerbation, and put them into matrix, and the treatment is decided based on that. So your Gold A criteria, where patient has got less number of exacerbation or less risk of getting exacerbation and is less symptomatic, probably this patient can be put on either of therapy, that he can be put on any short-acting or long-acting bronchodilator. Look at group B, where patient does not have any exacerbation but is symptomatic. Your first line option could be a LAMA or LAMA. And if patient could be, if he's more symptomatic in that sense, you could probably give them a combination of LAMA and LAMA. You look at C category, where probably patient has got higher risk of getting exacerbation, but is relatively less symptomatic. You can choose one drug, and probably LAMA is found superior in various studies. And then we recommend that you can initiate patient, if you're planning to put them on single therapy, you could put them on LAMA. But if patient has got more probably severe symptoms, you could think about putting them on LAMA and LAMA. And if patient has got exacerbation is still into that group, you can consider adding steroids. So you could put them on LABA plus inhaled corticosteroid, or you can give LABA or LAMA combination. And then comes the Gold D, where it is probably highest chance of getting exacerbation and patient is more severe. Here you can, this patient would be classically on LABA and LAMA combination, and you would put them on third drug, that is inhaled corticosteroids. Here, if patient continues to have further exacerbations and he's more of obesity, more of frequent exacerbation type, you can consider roflumilast as a drug. And if patient is a smoker or ex-smoker, or he's got predominantly more of neutrophilic kind of inflammation, you can consider having a macrolide there. So this is how group D treatment is decided. Very interestingly, here Gold for the first time gives you options for stepping down. That means if patient's symptoms come under control and exacerbations settle down, you can actually de-escalate from triple therapy, that is LABA, LAMA, and inhaled corticosteroid, withdraw inhaled corticosteroid, and put these patients on dual bronchodilator. That means these patients can be maintained only on LABA and LAMA combinations. So this is on the initial evaluation. On follow-up, if patient comes to you and he's got persistent breathlessness, if he's more dyspneic, and patient is either on LABA and LAMA monotherapy, you can put them on LABA and LAMA combination therapy. If patient does not improve at that stage, you would consider for comorbidities, associated disease, compliance, etc. You may even think of changing the inhaler device or the molecule. You've chosen one particular LABA and one particular patient is continuously symptomatic. It is recommended to put them on dual bronchodilator. It even tells you to add phosphodiesterase inhibitors group, that is a thiobalin group, and then inhale corticosteroids or mucolytics. The patient continue to be symptomatic or gets continued exacerbation. So implications are, it opens up opportunity for any patient to step up to inhaled corticosteroid to LABA if there is exacerbation risk. If exacerbation risk is identified, preferred step-up route would be either LABA and LAMA. That means you don't need inhaled corticosteroids in majority of the patients. Dual therapy is currently preferred prior to escalating to triple therapy, and hence most effort should be put on giving them a combination therapy with dual bronchodilator and increases the possibility of de-escalation of inhaled corticosteroid, which is given for the first time in the situation where patient's exacerbation reduces and patient comes into relatively stable state. You can safely think of removing inhaled corticosteroid. The key change which happened recently, that is 2019 update, it talks about stopping inhaled corticosteroid. And we have enough evidence of it says that probably in majority of the patients of COPD, you may not need inhaled corticosteroid. One would be extra careful if you have a eosinophil predominant variant, or if you have an asthma COPD overlap, or if you have a more of asthma kind of phenotype of this patient, you would continue inhaled corticosteroids. Otherwise, in most other COPD, you can safely remove inhaled corticosteroids. There were some studies which spoke about increased exacerbation rate and symptoms on inhaled corticosteroid withdrawal, but various studies after that looked at removal of inhaled corticosteroids on background dual bronchodilator therapy did not demonstrate further loss of FEV1, only in patients who had eosinophilic predominant disease or the sputum eosinophilia or peripheral eosinophilia were high, they required inhaled corticosteroids. Pneumonia risk probably was more studied with fluticasone furet, but it says that there are enough high quality evidences that inhaled corticosteroid use is associated with high prevalence of oral candidiasis, hoarseness of voice, and pneumonia. And this risk has been confirmed in inhaled corticosteroid using fluticasone even at low dosages. And that makes us think about what is the role of, what is the probable indicators for inhaled corticosteroid response in COPD. So in which kind of patients would you consider inhaled corticosteroids? So you have people who frequently have exacerbation, and inhaled corticosteroid with LABA would improve lung function and health status, would reduce exacerbation in frequent exacerbators who are moderate to severe COPD patient. So there is no role of steroids in mild cases. Only if you have a moderately severe patient and who get frequent exacerbation, you would probably consider using inhaled corticosteroids. And patients who have features of asthma, you would think about putting them on inhaled corticosteroid. So you have atopy, you have allergic rhinitis or family history of asthma, and then this patients have a combined picture. Probably this is what we are talking about, asthma COPD overlap. You would consider using inhaled corticosteroid. Otherwise, most COPDs would not require inhaled corticosteroid. And this is quite logical. Look at this graph. If you increase the dose of steroids, you probably increase the side effects, and hence there is always a question to give or not to give inhaled steroid, because whenever you give it, it comes with its own cost. LABA and inhaled corticosteroids combination in management of COPD. And then look at this. With use of inhaled corticosteroid, there is no evidence that disease progress or mortality are significantly reduced. This is come in Gold 2020. LABA and inhaled corticosteroids are considered as first choice only in some patients where blood eosinophil counts are high or there is history of asthma. And there you may use inhaled corticosteroids. And in Gold D, where probably you have patients who are on dual bronchodilator and getting frequent exacerbations, and probably you need a third drug, there you would think about inhaled corticosteroids. Otherwise, you don't need it. And let's look at a couple of reviews what happened in literature. So this is inhaled corticosteroids and FEV1 decline in COPD, a systemic review which came last year, and it looked at changes in FEV1 in studies and follow-up for 1 year or less. And you could see that 3 months, 6 months, 12 months. It says 8 out of 10 studies showed that change in FEV1 increased more or decreased slower in inhaled corticosteroids compared to non-inhaled corticosteroid. That means inhaled corticosteroid probably did little better. But if you look at this follow-up study, which went for more than 1 year, it did not speak the same. And it says that decline in FEV1 in studies greater than a year is seen both in inhaled corticosteroid and non-inhaled corticosteroids containing medication. It would raise a question whether ICS containing medications are similar to non-ICS containing medication over a longer period of time with respect to their lung functions. And hence probably these effects were not seen over a longer period. Most of these patients probably had similar decline in lung function when studied over a year. Again, blood eosinophil count. There is a lot spoken about blood eosinophil count and role of inhaled corticosteroids. And look at various studies again included here. Risk ratio for exacerbations in COPDs receiving inhaled corticosteroid versus non-inhaled corticosteroid containing regimes. And you could see that exacerbation ratio. And it favors probably, it gives you a kind of mixed picture, and it cannot be concluded. And you definitely need further studies for better understanding on changes in FEV1 when inhaled corticosteroid containing medication medications are prescribed, whether they are really required and whether they influence the decline in FEV1 over years. Sorry. The risk associated with inhaled corticosteroids, I mean, why are we so worried about it? Because there is definite risk which is associated with it. There are various trials, 11 RCTs in stable COPD patients treated with inhaled corticosteroids, and author concluded that administrations of inhaled corticosteroid were associated with 34% increased risk of developing pneumonia. There was Singh et al. Trial which looked at 18 trials. They analyzed 18 trials with more than 17,000 patients when ICS was associated with increased risk of pneumonia compared to controls. But there are some other studies which probably did not have any increased evidence of pneumonia in their observation. Putting all together, association between, there are so many other trials which are going on, which looks at meta-analysis of various studies, and they've looked at it, and their association with pneumonia is, there is a various observation. And when you put most of this together, look at no inhaled corticosteroids, low dose inhaled corticosteroids, moderate inhaled corticosteroids, and high dose inhaled corticosteroids, and you can see that risk compared to no inhaled corticosteroid, it is obviously that it is a dose response relationship. You use higher the dose and there are definitely higher risk of developing pneumonia. Not only pneumonia, other systemic complication would also be seen with inhaled corticosteroid use, and this is the risk of bone fractures. So you will see all possible side effects of inhaled corticosteroids that you see with systemic corticosteroid when you use it in high dosages, and it is mainly because of its blood absorption. So when you use high dose of inhaled corticosteroid, they are systemically absorbed and they give you all possible systemic side effects. How would you withdraw inhaled corticosteroid? You may have patients who are already on inhaled corticosteroids, and there are various studies which looked at withdrawal.
You have to sum up, Dr. Vora, please.
Most of this study talk about how do we withdraw inhaled corticosteroids, and all studies except wisdom tells you that even abrupt withdrawal of inhaled corticosteroids is not associated with sudden deterioration or insufficiency or any other thing that you can think of. And most of this time, your dual bronchodilator therapy would be enough to maintain these patients on adequate symptomatic control. And hence, if you really look at what is the place of inhaled corticosteroids today, according to the recent Gold 2017 onward guidelines, and it tells you that probably inhaled corticosteroids are required only in group C, where patients get further exacerbations in spite of being on dual bronchodilators, or if patient has got asthma phenotype. And in group D, when there are persistent symptoms, when there are exacerbations, patient on dual bronchodilators, you would give them inhaled corticosteroid before you consider them for either roflumilast or a trial of macrolide. And interestingly, for the first time, it tells you about stepping down. So there is a provision for step down. Once you have put your patient on triple therapy, one patient is stable, once the exacerbation is taken care of, you can safely withdraw inhaled corticosteroids and continue them only on dual bronchodilator. So if your patient is currently on inhaled corticosteroids and LABA, what would you do? So you have a patient who, according to previous understanding, if this patient is on steroid-containing regimen, and in this case, you can safely withdraw steroids and put them on LABA-LAMA combination, provided they do not have asthma COPD overlap, they do not have predominantly asthma phenotype, and they do not have eosinophilia either in sputum or peripheral. If you have newly diagnosed COPD, patient is in B and C category, probably patient with high exacerbation, you would think about putting them on inhaled corticosteroids, or if patient has got high eosinophil count, you will put them on this combination. In summary, I would say that role of steroid in COPD is doubtful. You have various trials which tells you about the advantages of using inhaled corticosteroid. There are some trials which talk that probably exacerbation rates are similar in steroid or non-steroid containing regime. There are certain trials which tell you that LABA and LAMA combination is equally good and probably does not, inhaled corticosteroid does not give you any added advantage. And then there are certain trials like Wisdom which tell you that probably step down withdrawal of inhaled corticosteroids during triple therapy is possible without significant risk of moderate to severe exacerbation. In the end, I would end my presentation with this statement by ARS that there is a conditional recommendation for withdrawal of inhaled corticosteroids in patients with COPD, but without the history of frequent exacerbation. In the sense, in patients where there is no history of frequent exacerbation, you can safely put them off inhaled corticosteroid. So if patient is already on inhaled corticosteroid, you can safely remove it. If patient is not on inhaled corticosteroid, if his NIF coming to you for the first time, you can safely put them on LABA and LAMA combination. Not to withdraw inhaled corticosteroids in patient with blood eosinophilia of more than 300, and to treat with 1 or 2 long-acting bronchodilators if inhaled corticosteroids are withdrawn. And hence, probably the take-home message is most of the COPD patients who are symptomatic would require a dual bronchodilator therapy, and your LABA and LAMA combination is must. If this patient has got asthma phenotype, if this patient has got eosinophilia, or if this patient has frequent exacerbation, you may continue inhaled corticosteroid, but inhaled corticosteroid comes with its own cost, with its own price, and high dose inhaled corticosteroid will have all possible systemic side effects that you see with systemic steroids. Thank you very much. I thank you for your patient hearing.
Thank you. Thank you very much. I think we will now open the session for question and answer, and we have few questions. And Dr. Shorkar, I think we have few questions on the chat box, and I think some of them have already been answered. Can I start with, I've got a couple of questions, and the first couple of questions will go to Dr. Khanna. So may I start off with this, Dr. Khanna? Please, you mentioned about sputum eosinophilia, which I don't do because of lack of facility at my site. I make do with blood eosinophilia. And number 2, you mentioned about alpha-1 antitrypsin, which also I do, but I don't know why I'm doing, because I don't know of any place in West Bengal where they are doing replacement therapy with ATT. Do you have any supply of ATT in Delhi?
Sure.
You know of anybody or any panelist know of any center or the availability of ATT?
So I'll answer the first question first, the sputum eosinophils. And as I absolutely, I agree second with what you say, sir. They're not available even at my center. AIMS does, there's one person who's doing a PhD on sputum eosinophils in AIMS. So that is one center where you can send your patients to get it done. Otherwise, Dr. Talwar does it in Metro. And then even then it's an off and on kind of a thing. So sputum eosinophilia, easier said than done. And that is what I said. It is a luxury. If you have your, hands on it, probably as a research tool or as a thesis topic, if one of your PGs, and if you have the facilities for it, you can do it. Otherwise, as you very aptly said, that we do with peripheral eosinophil counts. But my problem with peripheral eosinophil counts is, sir, we do not have a cutoff value for India. Our eosinophil counts are obviously different from the Western eosinophil counts, given our allergies and our worm infestations and the kind of tropical environment that we live in. So there's a good study going on from India where they're actually trying to, finalize the normal eosinophil counts for Indian population. And in fact, West Bengal is the place where the study is being conducted. Hopefully by the end, it was supposed to come by the end of this year, but I don't know, because of COVID, probably it's been delayed. So sputum eosinophils, big problems, sir. As far as alpha-1 antitrypsin deficiency is concerned, if you see Western literature, I heard someone at ATS saying that they do it for every patient, every age, every patient. Obviously, that is not possible in India, and it doesn't make any sense. So if I have a young patient who has a pan-acinar kind of an emphysema, a more lower lobe predominant emphysema with liver involvement, I would suspect, alpha-1 antitrypsin deficiency in them, or a very young patient coming with unexplained severe obstruction on a PFT. So there is one center for genetic diseases in Gangaram Hospital in New Delhi, and they have a tie-up with, I think, Cincinnati or someplace, wherein they do get replacement. So I've heard of a couple of people who have been in touch with that Center for Genetic Diseases with Gangaram Hospital. Dr. I.C. Verma is the contact person there. But I'm not very sure, sir, if they're getting replacement therapy or not. But that is where we are supposed to send our patients in Delhi if we ever get our hands upon one such patient.
Sorry, Dr. Shorkar. There's another thing which you mentioned is the muscle mass. I make do with BMI. And do you have fancy tests for muscle mass estimation at your center?
So BMI would be a very poor correlator of, muscle mass index, because, a lot of patients with the COPD would be having water retention, might be obese otherwise, and would have high, BMIs. So yes, at my center, fortunately, I do have access to a body composition analysis machine. The local gyms, all the local gyms have actually started keeping BCA machines. A very cheap BCA machine is available for the tune of almost around 50,000 rupees. So it's not very expensive. So in fact, one of the good pharmaceutical companies which sells the protein supplements, one of the biggest companies, I'm not taking any names, they actually did, they gave us a makeshift kind of a BCA machine, which is not the exact BCA machine, but a dummy kind of a small, kind of small spirometers that we have. So it is a substitute BCA machine that we have at our center. It is a rented, lend kind of a machine. We didn't buy it. But yeah, as a part of our protocol, we do tend to do it. I have access to it, so I do it.
Thank you. Thank you.
Dr.
Sarkar.
Yes. So another delicate, it is the question for Dr. Arjun. And one delicate asked about the 6-minute walk test. So do you use it regularly in your clinical practice, or just to tell us how it can be used in the clinical setting, how to interpret it particularly with relation to oxygen requirement for the patient, or assessment for pulmonary arterial hypertension or associated cardiovascular comorbidity?
I
Please
think
elaborate.
the most wonderful, one of the best tests that can be done in respiratory medicine is a 6-minute walk test. Unfortunately, still very underutilized. The beauty of a 6-minute walk test is that you do not require too much, you don't really require a lot of instruments in it. You just need standardization values. You just need a corridor where the patient can walk, a pulse oximeter, and a trained person who can do it with a BP instrument. So if you talk about 6-minute walk test, it has a role in almost every respiratory disease, whether you want to see the functional capacity of that patient, whether you want to see the drug efficacy of a group of drugs, especially in patients who have pulmonary hypertension. Even if you look at good trials of, COPD, where trials have been done on advanced COPD patients, 6-minute walk test is a must. So it's a very simple test. You need a trained person who can carry it out. Obviously, it requires only 6 minutes, and you need a clean space where the patient can walk for 6 minutes. And you measure the pre and post oxygen saturation. You see the time which the patient has taken for the oxygen saturation to recover. And the 2-chair test with Dr. Bhattacharya, Dr. Parthasarathy so passionately talks about, and we all know that it is a fantastic test, and it is a surrogate marker for 6-minute walk test. And a walk test in any form, for example, for our COVID patients, we are doing the modified 3-minute walk test, just asking them to walk and seeing if they're desaturating or not. I think it's a wonderful test which points out at the pulmonary vasculature and the interstitium of the lung. So in my practice, a rough 6-minute walk test is something that I would do for every patient who comes to my OPD. I would not do a 6-minute walk test, the formal 6-minute walk test that obviously we would restrict for a certain subset of patients, and where I want a follow-up of a patient of ILD, where I want to titrate their therapy. But otherwise, I keep telling it to my PG students also, whenever you have a patient of unexplained dyspnea in your OPD, and you're not very sure, you've not had basic investigations to find out what is wrong with your patient, ask them to walk in the OPD. And very often, patients who have an interstitial lung disease and patients who have a pulmonary vascular disease, that gives you a very good clue. The patient walks for 2 rounds and the saturation dips immediately and goes down to as low as 85, 80. And, whereas in obstructive airways diseases, unless the disease is too advanced, the patient would not have such severe hypoxemia. So it is a very useful screening test. And it is something that I wish that more of us would do. But then again, sir, COVID is changing a lot of our practice guidelines, and we would not really want to expose a lot of patients to formal testing as of now. But yeah, as soon as COVID goes away, I would want to redo more of it.
Can I comment on what you just said? 1 or 2 things that I want to comment on. One is not every hospital has got 30-meter long corridor. And that is the only thing which has been validated. And now there are a few hospitals which are doing it with a 15-meter corridor, and they are doing by turn. Now, if the patient has to turn around that often, that is not validated. That's one. 2, I do the same thing as you just mentioned. I quite often walk my patient on the corridor, in my OPD. But the problem with that is it is very crude evaluation. And the significant drop has to be 4% from the base level. And now the thing is, the reason why I'm saying this is that one of my colleagues came with a breathlessness, a never smoker, and I thought of pulmonary embolism, and he walked for 100 meters on the corridor, and it never dropped. And only after CTPA, we found out that he had, so not every time we get a success.
Absolutely.
So if you remember all these things, then it is a fantastic test. I absolutely agree with you. Right, Dr. Sharkar.
Yes. So another question for the, yes, thank you, Dr. Arjun, for this elaboration of this 6-minute walk test. And regarding the use of BNP or anti-BNP, which is better? How will you interpret this? Use of BNP and anti-BNP in COPD patients?
I think this test has more of a utility in patient who comes in exacerbation or in persons who we are not able to control the symptoms, and we feel that the patient has underlying cardiac comorbidities. Definitely, anti-pro-BNP is better than pro-BNP, and the cutoff value has defined, and more research is being done on anti-pro-BNP. The only thing is that most of the time these tests we usually done in patients who comes in acute exacerbation where we are not able to find any cause. All the patient has a label of COPD. We are not able to find any exacerbation cause, and echo are more or less normal, as cardiologist has also mentioned that it is very, very difficult to get diastolic dysfunction, especially in patient who has emphysema and so much dyspnea. So this test definitely has a utility in patients who had acute exacerbation, and I always go for anti-pro-BNP. But out of which, whatever is available, if it is mildly raised, then both the tests has probably same sensitivity.
Can I mention something, Dr. Sharma? I actually had a patient with CKD, chronic kidney disease, and it was pretty advanced disease. And then I was trying to find out whether anti-pro-BNP is valid in that sort of a patient, and whether we should do a pro-BNP instead of an anti-pro-BNP, because my center has got only an anti-pro-BNP and not pro-BNP. Then I searched the literature and I didn't find any difference really. So if you have anti-pro-BNP, we do the anti-pro-BNP, and if you have pro-BNP, I think that is good enough as far as my understanding goes. So my cardiologist colleague, if anybody is around, will tell me differently. But that is the literature which I thought I read, and that is my understanding. So in kidney disease, which really sometimes can affect the anti-pro-BNP value, both are more or less the same. So both are affected. So it's not that only anti-pro-BNP is affected, which I thought it was.
So anyway, it has to be, it needs correlation with the clinical features actually. So when you doubt whether how much the cardiac component is producing the symptom and how much the respiratory component is producing the symptom, there is some role of assessing this BNP particularly. So another question is from a delegate regarding 2D echocardiography. So
I think Sumit has elaborated this,
yes,
and I completely agree with Dr. Sengupta. So we need not just 2D, but the whole echocardiogram. And I absolutely agree with what Dr. Sengupta says, that we have to liaise with our cardiologist colleague, and so that he knows what we want. And my echocardiograph, who does the echocardiogram for me, she knows that she has to look into the right heart. She has to give me all the values. So I think it is a very good point that Dr. Sengupta has made, that we have to tell our cardiologist what we want. And then only we will get more information. And that's right.
Yes.
Any other comment from any other panelist?
Yes. Dr. Sumit is not there. Dr. Arjun, do you want to comment on 2D echo?
So,
what exactly we want to know as a pulmonologist from the cardiologist
Exactly, sir. So they have to be in the loop. That is very, very important. And they need to understand that, we are not trying to look at, we want something about the diastolic heart failure and the right heart and the pulmonary vasculature. So it is always a combination with the Doppler. So obviously one doesn't, most of the centers would actually combine a Doppler always with a 2D echo. And there's always this question of, when to do an echo in COPD. So ideally everyone, because the risk factors are common, elderly male patients, and because it is a non-invasive test, it can easily be done for everyone. But if you ask me which specific patient you want to get a 2D echo done, obviously for severe COPDs. But then there is this group called Group B COPD. If you go back to the gold B, why is this patient important? This patient, if you see in that gold box, a Group B COPD is a patient where the lung function is not too bad. The patient is not having too many exacerbations, but still the patient is very breathless. So Group B is a patient where despite having good lung functions, despite not exacerbating, the patient is still breathless. So if I have that phenotype of COPD in my clinic, wherein I see that, I don't think that the COPD is too bad, but the patient is still very breathless, this is the comorbidity predominant COPD. This is the guy who has a cardiometabolic, heart failure, diastolic heart failure, sleep apnea superimposed on his COPD. And that is why even at okay lung functions, he's not doing too well. So I think in those patients, a 2D echo and a good cardiac evaluation is an absolute must. And we would combine the whole jing bang with it. We would want a Doppler and absolute values and diastolic heart failure. Absolutely. We would want all of that.
Yes, so then we must know how to interpret it. Actually, they give us a report whether actually the patient has pulmonary arterial hypertension. So right ventricular systolic pressure, how to interpret it, whether it is a mild, moderate, or severe degree of pulmonary hypertension, how to calculate it. To some extent, I think we as a pulmonologist should go ahead and we should know that. And there's a heart failure with preserved ejection fractions, particularly left ventricular hypertrophy and diastolic dysfunction is an important component which can occur in these patients. So for the assessment of pulmonary hypertension, for the assessment of pulmonary left ventricular hypertrophy, it is needed to evaluate the patient with this.
I just mentioned, I think that way, I think I fail every time because most of the time I'm dependent on the cardiologist's report. Whereas when it comes to PFT, I do my own reporting. So I know which one I can sign, which I should reject. Whereas when I get the echo report, I do not know that. And I think we need to know a bit, all of us.
Yes.
We need to know a bit more echocardiogram so that we can see the report and see whether that has been done properly or not. That is my feeling over all these years. And I think we should all know about the echocardiogram a little bit more. So we need to be trained. I'm not saying that we have to do the echocardiogram. All I'm saying is we need to identify which report we can trust and which not to. So that's all I want for me to know.
Yes, definitely, you are true. And regarding this cardioselective beta blockers, there is underuse of the cardioselective beta blockers. And can you tell me, Dr. Rahul, now which cardioselective beta blocker you think about is safest and in what dose you want to use in this?
I think there are two cardioselective blockers that has been done in most of the studies, that is carvedilol and bisoprolol. And both of these are shown to be improving the survival as well as mortality in most of our patients and even in research. And there is one study which showed that bisoprolol has some role in preventing the exacerbation in COPD. I don't know whether it is the acute heart failure that is being misinterpreted as acute exacerbation of COPD, but yes, there is a literature which says that bisoprolol is even better than carvedilol when we are using these patients in most of our patients. But starting these beta blockers, I think it is must that we must take a cardiac opinion, because not only beta blocker, the patient has to have a complete cardiac evaluation if we feel that the patient has some kind of underlying cardiac disease. So it is always better to keep the cardiologist in loop as far as the management of cardiac part of COPD patients are concerned.
Yeah, the important thing is we should not stop the beta blocker just because it is a beta blocker. So that is, I think, the take-home message. And bisoprolol, has been found to be slightly better than carvedilol, which has got an alpha blocker activity as well. Can I ask, there's just a little bit of comment. When Dr. Shengupta was mentioning about SABA and anticholinergic, and that whether it can affect the heart failure and worsen it. And then he says, no, it should be used. And I couldn't agree more with that, because there are studies now, and that has been studied. And if I remember correctly, the meta-analysis was done on 253 patients, if I remember correctly the number. And it has been shown that it does not. It is as good or as bad as placebo. It was tested against a placebo to see whether it is worsening the heart failure, both the SABA and the LAMA and the anticholinergic, the short-acting one, but they are not worsening heart failure. So they're safe in patients with overlap COPD and heart failure.
Okay, so there is another question regarding the bronchodilator. Dual bronchodilator, as Dr. Sarnaik, if he can comment on this. So dual bronchodilator, which LABA and LAMA would you consider the best and why?
In fact, the long-acting formoterol, sorbitol, both have been quite well evaluated now. If you go through the literature, there are hardly many trials head-on, one-to-one, like comparing one with the other. But both have been proven to be quite safe, as we were discussing the cardiac safety. And in terms of the bronchodilatory efficacy, both of them have been universally, like most of the trials, these are the two drugs very frequently used.
But the newer drugs are available in the market now. And I want to know from you, the newer LABA and LAMA are available in the market now, like indacaterol and glycopyrronium.
Yes.
And that,
in fact, if we look at when you have the comparison, these again have been shown to have good efficacy. The definite advantage is maybe like indacaterol, once a day you can use it. The compliance can actually improve in few of the patients. Initially, there are always, for a newer drug, the costing is a usual issue, the major issue for these drugs. But if you look at like outside the costing, look at the clinical efficacy, it has been comparable in terms of the safety profile, has been also been comparable to the previously salmeterol and these drugs, where the efficacy is almost at par, as per whatever trials have come up. But if you look at the individual single monotherapy head-on one-to-one, not many such trials exist.
No, it is a dual bronchodilator. Dr. Arjun, can you give your comment on this? Newer drugs are available.
Yeah. So if you talk about newer bronchodilators, and if you are talking specifically about combination bronchodilator therapy, I think the two head-to-head trials or the two major comparator arms you would want to compare between formoterol glycopyrronium and indacaterol glycopyrronium. The biggest advantage of indacaterol glycopyrronium is that you need to give it only once daily. But then again, that is also its biggest disadvantage. Why? Patients in COPD, especially those with advanced COPD, a lot of them have nocturnal symptoms. So what happens is that when you give them once daily indacaterol glycopyrronium during the daytime, a lot of these patients would have nighttime symptoms. Another thing is, whenever you give glycopyrronium, the total dose of glycopyrronium that should be given in one day has to be at least 50 micrograms. Any drug combination which is available in the market and is offering, is saying that you need to give it once a day and the total dose of glycopyrronium in that is less than 50, which is available in India, is not good. So the minimum required dose of glycopyrronium is at least 50 micrograms per day. The other combination which is available in India is formoterol glycopyrronium. I think the biggest advantage of glycopyrronium with formoterol is that you give it as a BD dose. You give it twice daily. So a lot of patients with COPD who have nocturnal symptoms, the nocturnal symptoms are taken care of. Till 1 month back, financial constraints were also obviously, they were to be kept in mind because indaglyco was very, very expensive as compared to formoterol glycopyrronium. But now that bridge has also gone away. So indacaterol glycopyrronium is now, it is inexpensive. The cheap combination is now available. All major brands, the prices have been slashed down drastically. So if you see, head-to-head comparisons of indaglyco versus formoterol glyco, Well, there are no such trials, in between these combinations per se. There are trials where combination formoterol glycopyrronium has been compared to glycopyrronium alone, has been compared to formoterol with inhaled steroid. There are Indian trials, there are Western trials. But if you ask me about a trial which has compared both these, no, there is no such trial. It would basically depend on what you are comfortable with. I am more comfortable with using twice daily formoterol glycopyrronium because I think it gives nighttime coverage to my patients.
So give clear-cut patient selection and prescription. What was the topic of Dr. Sarnaik? When you will use OD dosing of long-acting LABA/LAMA, which is available, when you will use BD dosing. So is there any chance of giving OD dosing here?
So if I have to give OD dose, obviously one would use indacaterol glycopyrronium and not use formoterol with glycopyrronium, because formoterol you would want to give split as twice daily, and you would want indacaterol. The biggest advantage there would be you are using an ultra LABA with an ultra LAMA, so you can give both as an OD dose. So yeah, if it works, then again, sir, the biggest problem, in Indian practice is easier said than done. A patient who comes with severe COPD, wherein the patient is a candidate for, dual advanced bronchodilator therapy, most of these patients in our country would also be on inhaled steroids. It is very difficult to find in India a patient coming to one of the doctors who are sitting on panel here. For us, seeing group A COPD or early COPD, we don't really see it in our practice. Our biggest problem is all we see is group D.
So there can be a place if the patient has mild to moderate symptom, and we want to give it. So in that case, this OD dosing can be given. But if the patient feels that nocturnal symptoms are present, in that case, we can switch to the BD dosing as well. Yes, thank you very much. And
can I? All right.
Yes.
Sorry, Dr. Khanna, I quite agree with what you said. My practice is to give the once daily dose and then evaluate the patient. If the patient complains of nighttime symptom, then I can always switch. That's not a problem for me. But the compliance is much better with OD dose rather than BD dose. So that's my only reason. And yes, I note the point when you said the cost. Yes, I quite agree with that. But the cost has come down, as you mentioned.
All these drugs are available in the DPI form. There is another question, whether this moderate to severe COPD patient can be used it effectively or can be used it comfortably. What is your opinion?
Very valid point, sir. Very valid point. We've been meeting the head of pharma companies as to why, because of the this thing, because of the whatever rules that they have. Because most of these were taken from international brands, and because of they could not. Now in India, even formoterol glycopyrronium has been launched in a MDI format very recently. One of the companies has launched MDI format, and it was always a big problem. On one hand, you have a patient where you want to give him good bronchodilators, but the patient has an FEV1 of 20%, 18%, and you really can't expect him to really suck in a DPI. That is a very valid point, sir.
May I mention something here? I have got a connection with UK, and in the UK there is no MDI formulation with that combination, the glycopyrronium indicaterol. All are DPI. Everything is DPI.
Yeah.
Everything is DPI. This ultra LAMA and ultra LABA combination. Now, why can't they make an MDI? The thing is, it is very difficult, as they say. It is very difficult for, I don't know, either to make it or to keep it. So I don't know the MDI which we are getting here, whether they're of the international standard, whether if I do a head-to-head trial with the MDI and the DPI, I don't know where it's going to stand. So that is the only reason why I'm slightly scared of using an MDI. I absolutely agree with your point of patient's ability.
Can I just add a point to that, sir?
Yes.
So both manufacturing as well as maintaining in MDI form, this combination is difficult. So we all know that. And, when it comes to the DPI formulation, which is available in, the Western countries, If you talk about formoterol glycopyrronium in UK and US is available as Bevespi co-suspension. So Bevespi co-suspension is a much better, delivery system as compared to the DPI that is available for use in country. If you look at indacaterol glyco or umeclidinium glyco, it is available as Cibri in US. That again, So that again, sir, it is a much better delivery device than the kind of DPIs that are available for these molecules in our country. Initially, first time when Novartis came out with Sequadra, they said that they are going to use the same device which was being used universally world over with what they were going to give us in India. Unfortunately, that did not happen. That happened only on paper.
In the UK, they're using the Breezella.
So they are using, sir, but somehow, sir, it makes good sense.
Thank you, Libit. So there is another question from the delegate about this single inhaler triple therapy. What does it mean, and where we can use it straight away in the COPD patient? Dr. Rahul, you can respond to this question. Dr. Rahul? Single inhaler triple therapy is also available in the market.
Yes, that is also available nowadays in India. Most of them are again in DPI, and there are MDI forms are also available. But again, you need to go by the GOLD protocol to consider any patient for inhaled corticosteroids. Otherwise, I believe that most of the patients that we are seeing is either on inhaled corticosteroid when they are coming to us. So we can add LAMA-LABA or add a LAMA and then try to taper it off. Then, because most of the time what we see that inhaled corticosteroids needs to be taper off if you can taper off in your COPD patient. But yes, there is a subset of patient, as Dr. Arjun highlighted, with eosinophil count or even a variant which is not responding to your dual therapy, and they are recurrent exacerbator. Probably you want to try triple therapy in these patients, and if these patient has any kind of compliance issue, and most of the time there is a confusion that you give one device as DPI and other device as MDI. This is very, very important that you give everything in the same device so that the patient compliance is better and patient can take it in a very similar way and get the maximum benefit out of it. So triple therapies are, yes, it is there, still valid for a slight subset of patients which gets the maximum benefit of it, not for everyone.
Yes, thank you. There is another question from a delegate for Dr. Agam Bora. Dr. Agam, are you present here? So question is that how frequently you see pneumonia in your COPD patient using ICS in any combination? How frequently you see pneumonia? And whether it is a fluticasone or the class effect for the inhaled corticosteroids. Dr. Agam?
I think we have the same problem because there is. Oh, Dr. Bora is there. Dr. Bora, that's a question actually is for you.
Dr. Bora? Are you here?
There is I couldn't hear your question well. Will you use the question again?
The question is how frequently you see pneumonia in your COPD patient getting treatment with inhaled corticosteroid and any other combinations, ICS containing drugs. Probably there is internet problem with this.
I think there's a technical issues.
Yes, again, Dr. Arjun, do you want to comment it?
Yes.
So if you look at the pooled data from UK, and if you look at the earlier studies from all the important earlier studies with inhaled steroids, the figure is said to be 4:1. It is said that for every 4 exacerbations that you prevent, you cause 1 extra pneumonia. But I think that is somehow blown out of proportion when it comes to our practice. I don't think it is 4:1. It is much lesser than that. All of us, in Indian practice, we have used inhaled steroids in almost 90% of our patients with COPD, more than 90%. We know pneumonia is a problem in these patients, but I think more than pneumonia, exacerbations are a problem in our Indian patients with COPD, wherein the lung functions are very poor. The patients do not have well-controlled disease. So I don't agree with the Western data there, 4:1. I think it is much, much lesser in our country. And when it comes to, which molecule is worse, whether fluticasone or budesonide, so fluticasone is a more potent steroid It is a more lipophilic drug. It binds more avidly to the receptors. So it is said to be a more stronger steroid. It has a longer half-life. It has a better, it remains in the pulmonary parenchyma circulation for a longer period of time. So it is said to be associated with a higher percentage of pneumonia. So it is not that budesonide is innocent and it would not cause any pneumonias. But yes, if I have to choose in a COPD patient, I would want to use budesonide because it seems to be a softer steroid in these patients. And whenever possible, I would not want to really give fluticasone to these patients. Although there are again head-to-head trials between combinations, in patients with advanced COPD, wherein fluticasone has been compared to head-to-head with budesonide along with other LABAs and LAMAs, and the incidence of pneumonia has not shown to be higher when fluticasone was used. There are other studies wherein, in patients with bronchial asthma, young patients, where fluticasone as well as budesonide were studied head-to-head. In fact, higher pneumonias have been shown with budesonide, which should not be there. So none of the drugs are, sacrosanct, and all of them can cause. So you need to.
So it can be a class effect. It is a class effect.
Can I add here something?
Yes,
can
regarding one minute, please. Regarding fluticasone, there are two molecules are there: fluticasone furoate and fluticasone propionate. And I think fluticasone furoate is staying in the lung for the longer period, about 20 to 30 years. That's why there is more chance of pneumonia in these cases. Whereas propionate stays for few hours, 8 to 10 hours, so less chance of this. So that's why some of the preparations are made with fluticasone propionate. And another thing, just a simple silly questions: why the pneumonia asthma patients are not so much the risk of developing pneumonia? We are using so much high doses of corticosteroids. Why COPD patients are at risk?
I think so, because probably they are elderly, they are more immunocompromised. Cigarette smoking leads to worsening of lung immunity. It damages their alveolar macrophages. And because a lot of these patients have been on oral steroids for a long period of, even inhaled steroids for a longer period of time, I think all those factors, and because these patients have been given frequent courses of antibiotics, it alters the lung microbiome. I think all these factors combined together would probably put them at higher risk.
So another factor is mucus plugging.
Mucus plugging, of course. Yeah.
Thank you.
May I just add one thing? Dr. Khanna, the only thing, I quite agree with what you said about the steroids. Fluticasone is a stronger steroid. However, the dose that we use, if I use a medium dose, which is 500 mics, a medium dose fluticasone and medium dose budesonide, which is 400 mics, then the effect is exactly the same. It only separates, diverges at the higher dose. So the torch used a very high dose of fluticasone, 1000 mics. And that's why the subset had the problem of pneumonia. That's what I think. But we know that COPD doesn't need that much of steroid. At a medium dose or a low dose, they work exactly the same. There is no difference.
So dose and duration both are important. High dose for long period of time, there is a high risk of developing pneumonia. But again, they saw small subset of patients are developing pneumonia. They are called high risk patient for the development of pneumonia. And we should avoid the ICS in these cases. So not all the patients are at high risk. So how to select these patients? They should not use ICS at all. Is there any particular subset of patients, high risk patient for developing pneumonia?
Elderly, non-smoker, elderly, I would want to, so that's, it's all about phenotyping. So you don't want to give it to a patient who has a risk factor, who has a history of having recurrent pneumonias, patient who has uncontrolled other diseases which are causing immunosuppression. And, you need to just be careful. It is not that every patient of COPD blindly continuing inhaled steroids for a long period of time. I think that is something that we need to move away from. But per se, I don't think there would be any patient, who would come with a black box warning that, no, this patient should not be given an inhaled steroids. Because any patient, if he has a exacerbation, we would somehow, end up using steroids in these patients, at least for a small period of time.
So particularly elderly patient having low BMI, particularly. BMI is importantly highlighted here. Low BMI and having high risk, high grade of disease, high frequent exacerbation, and worsening of the lung function, and particularly a history of pneumonia and hospitalization. Thank you. Thank you very much.
There's one question here, which I cannot answer. Lung ultrasound to differentiate between COPD exacerbation and heart failure combination. Anybody? Lung ultrasound?
So I think me and Dr. Arjun, when we were doing our DM fellowship program in substance, we were doing a lot of lung ultrasound together, and
We still do
especially
it
in the
all the
patients,
time.
we did
Very fond of it.
yeah. So I think two studies that we did there was one was with the ultrasound and other with the BNP markers. This was the study that we did in substance that we tried to correlate the value of BNPs with D dimer, and what we exactly looked in the ultrasound picture was B profile, which is mainly, or the comet tail artifact, which is mainly for the heart failure patients, and A profile, that is mainly for the COPD patients. So although this paper was not with me, it was one of our colleagues who were doing this paper, but we find a very good correlation of high BNP with lung ultrasound, and probably from there we all had this habit of doing ultrasound in each and every patient who is landing up in our ICU, and a lot of things can be very simplified when we are doing ultrasound in our ICU setup. B profile, definitely there is a volume overload, be it with or without COPD exacerbation. A profile, very unlikely that the patient has any underlying lung disease. Besides that, you can also evaluate the patient for pneumothoraces and other pneumonia development, ARDS picture, and a lot of things will be eased within 10 minutes of assessment of a lung ultrasound. So definitely it is a very good and quick non-invasive tool for the assessment of your patient when you are in confusion of COPD versus heart failure in your exacerbating patient.
Is there any change on lung ultrasound when the patient has got diastolic heart failure?
So, it's, as Rahul said, you have your diagnosis in a minute. Patient has acute breathlessness, has come to the emergency, and a 80-year-old person who has COPD can very well come with breathlessness and have concomitant heart failure as well. So all a lung ultrasound would be able to tell you would be if there is fluid in the lungs. It would not tell you whether it is due to systolic failure or due to diastolic failure. It would tell you there is fluid. You'll see cometing, you'll see the B lines, and you'll see the classical appearance of pulmonary edema. You put it for 1 second and the diagnosis is there. It is that easy. And no, it would not tell you whether the fluid overload is due to diastolic or systolic heart failure. But yes, it would definitely tell you, if you are expecting an exacerbation, you would not see cometing or you would not see B lines. You would see a normal lung parenchyma, or you would see a patch of pneumonia, which is so easily and beautifully picked up with the lung ultrasound. So yes, it is an absolutely fantastic tool to pick up an acute exacerbation of COPD and to
so the only thing that
heart failure.
The only thing that you can see with this, as Dr. Das Gupta was mentioning, that you be little more, educative about echo and just put a cardiac probe and see whether the ejection fraction is good or not. And most of the time, when there is a marked difference between low ejection fraction versus normal ejection fraction, and if you see a normal ejection fraction, although even I am not able to do a complete echo, but putting a probe on the heart, you can definitely differentiate between diastolic and systolic lung function. If you feel that the ejection fraction is poor, then you definitely go for low ejection fraction. Otherwise, B lines with normal ejection fraction, you always go for diastolic lung function in these patients.
He's being modest. For 3 years, he did nothing but lung ultrasounds. I think almost 20 patients every day, and that too along with the echos. So he does better echos than cardiologists. So he's being modest.
Okay, there is another question regarding inhaled corticosteroid. And most of the patient when come to the clinic, usually in open triple therapy, that is ICS LABA and LABA tiotropium, most of the cases. And when you decide to de-escalate ICS, and what is the de-escalation procedure you follows?
Oh boy.
So I think de-escalation process is again a very important thing. Most of the time we ignore this part. As far as we feel that our patient is absolutely fine, usually we don't want to touch that patient or change any winning combination. But yes, if we feel that the patient is at high risk of development of pneumonia, or patient has any kind of side effects that is being developed with the dose of steroids, then you need to taper it off. And most of the time, many of us are using the same trial that has been done in this wisdom trial. We try to see whether our patient is stable for next 2 to 3 months, try to half the dose, again see whether the patient is doing good. But most of the time, more often than not, hardly any patient is going off steroid until unless the steroid has been started by someone as a wrong indication in mild to moderate disease. But for the severe disease, it is almost impossible to get rid of inhaled steroid in COPD patients.
In the first step, you will just switch on to LAMA and ICS. Then you
Yeah.
gradually
Yes,
decrease
sir.
the ICS in that cases.
I think we have to wind up, Dr. Sarkar.
Yes, yes. Thank you very much.
It's been a long, long session.
Yes.
Now
you take the lead.
Partho, do you want to say a few words?
It's my pleasure and privilege to get you all out here in today's evening. I'm grateful to the speakers and to my dearest chairpersons. And this discussion has been very lively and very nice. So I congratulate you and I thank you profusely for joining our Pulmocon. Thank you, Arjun. Thank you, Rahul.
Thank you, sir.
We'll catch you time and again. Don't worry.
Thank you, sir.
Thank you.
And I wish our audience will be present on next Sunday for the next session. So with that, I wish you a good night. Bye.
Thank you, sir.
Thank you, Partho. Thank you, Arjun. Thank you, Arjun.
Thank you, sir. Thank you, sir.
Thank you.
Bye-bye.